Okay. So again, we're switching up a little bit just so we can get your right time started. So we're still going to hit on some of the other stuff. Since we've got it actually built in here. So starting with drugs. Start with drugs. Chemical agents used in the diagnosis, treatment, or prevention of disease. When we use this, we're going to call them medications. Please do not call them drugs. Especially when you're doing ride time up here, you'll get a different response. Probably get some friends, but because if you ask the question, do you take any drugs? Not raw, I'm clean. That's not what we mean, but I mean, that's great. I mean, like, do you take anything daily? I only use like once a week. No. So please use the term medication. Pharmacology is the definition that you need to know. Study of drugs and their effects on the body. Pharmacologists are scientists who study that. So obviously the derivatives of medications vary depending on what they are. Some are plant-based, some are animal-based, some are mineral-based, some are completely synthetic, meaning they're made in a laboratory. Most of the stuff that we have here will be laboratory-based, plant-based, or animal-based. Can anybody give me what they might think a example of each one of those are? Why do you have to help advise? What's a medication that's completely synthetic that a lot of EMS services? What? Fentanyl, correct. Fentanyl is a completely synthetic drug. It's obviously it's an opiate derivative, but to clean out some of the properties like your heroin, they have extracted some of the molecules in the formula to make it a completely synthetic drug. What is something that's animal-based that some services carry? I know we do, but I don't know what you carry.
No, insulin is one of them for sure.
Insulin can be. What else?
Which one is that?
Nitro paste, I believe, can. Can you say something? I don't know anyone who carries that, but it probably is. I'm trying to figure out who carries that. Heparin's the big one. It's typically animal-based. Plant-based can be a lot of things. What's your book saying some plant-based stuff? Atropine would be. Morphine. Heroin. Caplane skip. It's just a plant, but you should just happen to set it on fire. Yeah, so obviously they can come from a lot of other places. A lot of your over-the-counter stuff is mineral-based. Oh, there you go. Dig is a big one that you'll see in your older population that they take. Bicarb is obviously mineral-based, calcium, magnesium. All the ones that are on the periodic table will be element-based. So this is how, or references that you can use and how they're kind of broken down for our use. Obviously, no one's going to walk around with an encyclopedia for pharmacology. Like that would, I mean, a lot of you don't carry a pen, let alone a 10,000 page book of information. So I don't think that's going to happen, but they are out there. There's some over here on this shelf, somewhere over here, for formularies and whatnot. You've got non-official texts The biggest one you'll see is a USP dispensing information, that piece of paper that we always eat as soon as we get a prescription. It's either taped to the bottle, stuck in the box, or it's the 97 pamphlets that are after your prescription on the front of the bag. That's an example. I know in the field we typically can use either the internet or an app on our phone. Hippocrates is a decent one. Pill ID is a decent one. Drugs.com, RX List, those are all references. Typically I'll use those on legend situations where there is no bottle and I'm trying to ID a pill based off a number or shape. It's really good for doing that. And you can use them for side effects, interactions. If they have the medication you're not familiar with and you want to give something and you want to know, hey, is there an interaction with this drug? You can kind of check in those places. Or just what they do and what the effects are, because there's no way, and please don't think that there's ever any expectation that you're supposed to know every drug out there. Not going to happen. You should know classes of drugs and what they do, and when we get into that, it'll be more familiar. But I don't expect you to know every beta blocker, but you should know what beta blockers in general do. I don't expect you to know every calcium channel blocker, but again, you should know what calcium channel blockers do. And if you don't know them by name, that's fine. You look it up and it says, oh, hey, atenolol is a beta blocker. You're like, okay, good. Like, I don't need to know the specifics. I know that it's a beta blocker. That's what we're expected to know. So please don't think that I'm going to give you some random ass drugs out of the middle of nowhere and just you're supposed to know what they are. It's not going to happen. Pharmaceutical industry is highly motivated to bring profitable new medications to the market. That word right there. They're motivated to be profitable, regardless of what you or I or anybody in the world thinks, needs, or wants to know about. I know our county is getting several $1 million over the course of the next 10 years from Purdue Pharma for the bullshit that they pulled back in 2015. They will completely disregard public safety most of the time. So the federal government, i.e. COVID vaccine, to push out new products to the market.
I tried.
Did you?
Yeah. Unfortunately, they went that by going to a pharmacy that doesn't exist in the 90s.
Yeah.
It's unfortunate.
I mean, our county actually is the one that started it. Yep. Our commissioner started a lawsuit against it, and then a couple other counties were like, wait a minute. And they're like, can we join with you? And they're like, yeah, if we get a major percentage of it. We're like, okay. And then the state took it over. It's like, we got this. And then now the state gets 50% of what they give, and then the counties get the other 50%.
The highest payouts for like death were $200,000 to $400,000.
Which is nothing.
Not at all.
Nothing. But yeah, that was the whole Purdue Pharma thing. If we have time, there's actually a really good series. If you haven't watched it and you like, there's a really good one on Hulu. Dope Sick. With
Even though it goes away, it's fine.
that one, I've seen that one as well. But the one on Hulu, we watched it, I think, during our advanced class, maybe. Yeah. It's like an 8-episode series where we watch an episode each class over the course of pharmacology, and it opens your eyes. Like, it makes you mad, like, for real. But it's actually a really good series. Medications can become generic when original company's patent expires. So what that means is usually there is a 10-year patent on all medications. So that means typically all drug companies have 10 years to be the sole entity of those medications before another company can get the formula of it and make a derivative or a generic of that medication. There's different phases in testing. This is broke down in which part of your book? Page 6. You'll see phase 1, phase 2, phase 3, and then your NDA at the bottom, and then it goes into your post-marketing surveillance. I'm sure we'll go over that here. Nope. A couple of these actually that are good to know. not on here. AC means before meals. You typically see those on some prescription bottles. I think now most prescription bottles write it out because most people in the world don't know what PO or AC or Q2 or any of that stuff means. But there's some abbreviations there if you want to use them to get yelled at. So for newly approved medications, they'll have a numerical classification, that is their chemical number. They'll have a letter classification, which is a treatment or therapeutic potential, and then you can have other classifications on those as well. Like narcotics have their own way of classifying, whether it's a C1 through a C5. That just says how controlled they are. The C is controlled, and then what level are they controlled. Like a level 1 is cocaine. It's highly controlled and not used for medical treatments in most situations. However, our local hospital has 1 bag of cocaine in it for medical treatment. We are never going to get cocaine on the trucks. Like, that's not a thing. State would shut that down real quick. But a lot of hospitals still do carry some stuff like that because there are still some uses for it. The highest level that you'll ever see in the field in most hospitals carries the C2, and then it goes down from there. With these classifications, they allow practitioners to rapidly determine whether the medication is a new medication, replaces a current medication, or offers a substantial new therapeutic benefit. That's going to be typically, again, on these newer medications to let you know where they at in testing and what the efficacy of those is. Back to your phases. Phase 1 is the initial phase to determine the pharmacokinetics and toxicity. Phase 2 determines therapeutic medication levels. Between those two phases is typically where you see the animal testing, I believe. And they'll do LD50 doses, which are your lethal dose, to say how much does it take for 50% of these rabbits, rats, dogs, or whatever to die. And they go, okay, so we know what that is. Phase 3, after they figure out what that dose is, or if they have a high kill rate or a high lethal rate during one of their initial introductions of the medication, they'll refine that dose and study the side effects. Then they'll go into that post-market analysis where they'll start looking at side effects long-term on humans and regular rates, and they'll do the placebo testing if they need to, and all of those things for therapeutic thresholds. After that clears, they'll go through medication approval, and I do not know what the term orphan medication is. That's in your book. Someone can holler out to help. I don't think that's where they just give a bunch of orphans medications. My definition. So if you see what the definition is, that would be helpful.
All right, so the orphan drugs are drugs that are used to treat what are referred to as an orphan disease, relatively rare diseases that affect fewer than 200,000 people.
No one really developed it, but
There you go. Black box warnings. FDA requires manufacturers to prominently display warnings on a black box. Is there a picture of that in your book? A black box warning? I'll pull that up later. It is huge. It's not like, a little like, hey, don't touch me there. It is one side of the box is a black square with a red or white skull in it that says warning. There's several medications on the market that have that. We carry a medication here that is a black box warning. What that means is there is a high interactivity rate with it. There is a high death rate with it if it's abused. There is a high reaction rate. There's a high adverse effects rate. It's highly necrotic, whatever the case might be. If it's like that, a lot of your testing or trial drugs are black box warnings saying, hey, they went through phase 1, 2, and 3. It does some amazing shit, but it also does some unamazing shit. Use it at your own risk. And some of them will hit the market. And then, like the drug that we carry did not have a black box warning for a long time. Now it does. So it's kind of like, well, what happened to the last 20 years you've been using it? It was fine then, but what happens is over those 10 years, they've realized, hey, while this may be effective, it has some nasty side effects. This can minimize risk by assuring practitioners that they are familiar with the side effects, and then it lets them know that they need to educate the patient and we need to educate the patient. That's one thing that we are atrocious at here. Phenegrin, IV Phenegrin now has a black box warning. We carry that here. And most people just go to that without giving the side effects and what it can do to them, and we just give it. And that doesn't need to be something we do. Any medication you give, you need to say, even if it's nitro, hey, you're probably going to experience a headache. Well, that is what, because of what's happening in the body that's normal, you still need to tell them, hey, you might get a headache. So anytime you give a medication, you need to be familiar with the medications you carry and you can give, for sure, because you need to know the side effects, the adverse effects, what would be normal to see and what would not be normal to see. No way you're going to know the side effects of every medication on the market. That's why you use that Hippocrates, pill dose, and all those things are good things to download. Recent medications such as droperidol have received a black box warning from the FDA. Again, those can be on the market for a hot minute, and then the FDA says, we don't like this no more. And then, full disclosure, a lot of times it does have issues, don't get me wrong, but there's a lot of times that big pharma starts to pull their bullshit, and it's like, hey, that's a really good drug that competes with ours. We're going to put millions of dollars into testing to see what we can do to get that other medication a black box warning. Because if you go to the doctor, and we've got two medications that would treat this ailment. One of them has a black box warning. Which one are you not going to take? The one with the black box warning. Give me the one that doesn't kill me, right? So, big pharma pulls some bullshit where they'll say like, hey, Justin, here's $100 million. Look into this drug and figure out what we can do to get a black box warning that's not ours. That shit happens. Unlabeled use medications. This is my favorite gray area of paramedicine. Is unlabeled uses are utilized for that are given in the field, but they're not as the labeled issue or treatment for a certain condition by the product manufacturer. The medications, dosages, or routes have been utilized in emergency departments, ICU, blah, 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 and proven to be effective in emergency settings. So, Benadryl is one of the drugs that I used as an unlabeled use in the field. It's one drug it's not a drug that I only give for allergic reactions or anaphylaxis. Just because of the potentiating properties that has, and we'll go over that in a little bit. Those are unlabeled uses. Now, that doesn't say that because you mix product A with product B, you get product C, and that's really cool. You still have to articulate why you gave product A in its unlabeled use, or why you gave it knowing what you're trying to do, but you need to be like, this person had a rash, so I gave Benadryl. Now, don't make up a rash, but if you see a couple little things, they got a rash, and you just want to make sure they're not having anaphylaxis. And it just so happens to mix really well with fentanyl and enhance the properties so they get knocked down at a low dose.
Is that the whole nitro with hypertension versus chest pain?
Mm-hmm. Kind of.
Does your chest hurt?
Are you sure? Apparently, we were having this discussion before I left work yesterday that Trevor and another person brought someone into the ER, like walked in type. They didn't walk in, but they couldn't type deal. And Trevor had, I think, downgraded it to you maybe. And then he watched the doctor talk the patient into having chest pain.
So he did not downgrade that to me.
Oh.
But yes, because her ramp is number one, a fucking can opener. Number two, he literally just went in there and said, "You having chest pain?" First off, fuck you. No, she's not.
I guess that Trevor had asked, did his stuff and rounds. He's like, no. And I guess the doctor asked the patient like 4 or 5 times, like in different ways. So she's like, yeah. And there's like 12 lead EKG full workout. And Trevor's, why?
Yeah, then she sat there for 7 hours and we got transferred.
Yeah. For a troponin of 80 and the high marker is 76. Yeah. Since manufacturers can't conduct randomized blind studies in an emergency setting, the best practice and approval by medical direction is needed before use. So if you're going to use something in an off-label use and it's strictly going to be an off-label use, you do need to make that call. Now, again, if you can articulate, hey, this person had this rash or did this or whatever, and you can say, this is why I gave this low dose of this, that's fine. But if you want to use it for a full off-label use, you do need to make that call. You can't just be mixing shit in the back of the truck just to make it work. And I've had to do that before, just be like, listen, this isn't working, this will help, but I need your approval to give this dose of this, and I'm going to give this, and that is a potentiator for this medication, and that's what I would like to do. Medical director, we know who that is, I'm not going to go over that. Medical control, you've got two different kinds. You've got online or offline. Online may or may not be familiar with your local protocols. That's why I harp that you don't call the hospital that you're bringing to. You call your hospital, whether you're transporting there or not. If I call U of L, right, and I say, hey, I've got this traumatic injury, we've got a flail segment, we've got negative breath sounds on the left side, we've got some tracheal deviation, I want to go ahead and do a chest tube, U of L's going to lose their shit because they're going to absolutely not. Like, most services don't do that, right? I call my medical director and be like, why haven't you done this yet? So that's why you need to call the hospital that is most familiar with your protocols. Now, again, obviously the medical director is not the only doctor that works in that hospital. So you might get a doctor that's like, what? Depending on how big your hospital is here. You know, we've got 3 doctors here that we can call, and if they're on shift, Cross, Hicks, and Avery, that'll be like full send to the moon, right? Then we've got another 3 doctors that are really conservative or don't know our protocols, 2 of them being new, and 1 of them is super conservative that has no idea what we do. So it's really going to depend on who you call. I know like most of my staff here has our medical director's actual phone number, so if there is an issue, they can call him directly. But you need to call who you can that's most familiar. So if Norton's downtown is not where your medical director's at, don't call them for what they want you. They have no idea. They deal with 20 different ambulance services, and you have to remember, they're going to make the decision based off the lowest level of EMS service that's coming in there. And I don't mean that in a negative connotation, but that's what they're going to base their decision on. And if your protocols are different, they're going to hinder you from treating what you have the capabilities of doing. Medical control and protocols and guidelines. Guidelines are developed by the medical director. They're usually in conjunction with the service. Correct me if I'm wrong, Emily and Gage might know this. Clark County has 2 sets of protocols, one for the county and then one for your service, is that correct? I think Clark County is like, you cannot exceed this. It doesn't go anywhere, it's just, that is kind of given to the services that says, this is the ceiling for your service, and then your service has its own. Yeah.
It's only one set, but they've got it broken down to like paramedic 1 and paramedic level 2. And it doesn't really state what it is. And it's actually both counties, Floyd County and Clark County, have the exact same protocols.
So we just revised it. Dr. Yates just rewrote it, so there are 2, like New Chapel has theirs.
And then there's one for the county that
Yes.
you cannot exceed, correct?
Yes.
Yeah.
But Dr. Yates just, I mean, they haven't approved it yet at the meeting, but he just rewrote it, so.
Good.
Like Hazel's wrote ours, he was with ours, and we're getting RSI and a couple other things that New Chapel probably never have. It's someday.
Well, I mean, and that goes both ways. I mean, you have to look at the providers in the area, because I mean, every service is going to make mistakes. We make mistakes here. You guys have brought in something that was supposed to get a certain drug that the provider was too afraid of giving. That's going to go every day. You know, it's the whole, I mean, me and a lot of people from Clark County, not like from service or service, but officials or medical directors, whatever, have talked saying, hey, because they've called and said, hey, what are you doing here? What are you doing here? Where are you guys at with this? And they have to look at, it's not necessarily what the provider is, because anybody can be trained. It's how much training is your department doing? Is their department doing? Is Jeff going to do, or whatever, to say, are these people going to be familiar with it? Because you can carry stuff all day long, but if your providers aren't giving it, you're no better than the next service. You know, if we're too afraid to give Cardizem or something in the field because we've got AFib RBR and we can't recognize it, that doesn't make it any better if you're going to carry Guard. If you're going to carry ketamine, but you're too afraid to give it because of, you know, the increased properties of intracranial pressure, or because of the, you know, sedative effects or the possible hypokinesis and stuff like that, then you're not going to give it. Doesn't make you any better on it. So I think that's probably why the county did that. And a lot of counties where you see multiple agencies will do that just because they have to have some control over it. Protocols usually developed with input from various disciplines. Obviously, like here, I'm super involved in it. I'm typically the one that writes them, and then I bring them to Dr. Hicks, and Dr. Hicks will take a couple weeks to review them. Him and I will then have a meeting that says, why do you need to do this? Why do you want to do this? How is this going to benefit the people in the county, and how is this going to benefit your service? That is typically how our conversations start. And then after that, you know, he might tweak them. He might say, you're an idiot. Absolutely not. Or he might say, let's go ahead and get some training on this. After everybody's trained, we can go ahead and put this out in the field. Just like the chest tube thing here, for instance, I got that approved at the end of last year. We didn't put it in our protocol until I think March of this year, March or April, just because we had to buy trainers. We had to get everybody here the same day. And that's not something that, all right, I'm going to train Gage on today and be like, all right, it's in our book. You can do it, but you can't. I can't dictate that. So we had to wait till everybody could come to a training. Everybody could do it. We had to buy mannequins, had to buy the equipment and all of that before we roll it out. And that's typically how it's done. Medications are a little bit different because obviously there's not a whole lot of training on a medication. It's just knowledge based. But if you're doing procedures, there is a huge liability to the medical directors because most of them are coming to put on the training. So again, you cannot cover every imaginable situation or medication. It's not a thing. You're not going to know everything. And then you have your legal regulations or your regulators, your Pure Food and Drug Act, Federal Food and Drug and Cosmetic Act, Substance Act, drug standards is a big one. You need to know what those are and what they mean. They're in your book, highlight those. I will tell you, this portion that we're going over will not be on your module exam next week or the week after or your final. I'm just doing this today so you have more time for writing. Here's your schedules. Again, schedule ones are your heroin, your ecstasy. Oh no. Your MDMA, your LSD, pretty much anything that's sold out of a Haji Mart or someone's kitchen. Those are going to be your schedule ones. Your schedule twos, again, are where you'll start seeing these medications pre-hospital or in the hospital setting. Written prescription is required for these. You cannot, the big thing on here, schedule twos, you cannot have telephone renewals. So if you run out, you know, before, you can just call your doctor and be like, hey, I'm out of my Lipitor. They'd be like, cool, I'll call you some in. You cannot do that with schedule twos. They're not supposed to be required with schedule twos. They changed that back in 2019, I believe.
Yes. Right around COVID. People got wrong.
It started freaking out. But you cannot have telephone renewals. In an emergency, a prescription may be renewed by telephone, but it's not for a full prescription. It's usually 3 or 4 or 5, 5 days worth to get you through. It's not the full 30-day or 90-day supply.
I know some stuff has changed on that a little bit with telehealth coming out and becoming a big thing though. They're starting to do a lot of like telehealth.
They typically still have to have a hard prescription, or they have to have an associated pharmacy that can receive like, you don't get to pick your pharmacy at that point. It's, you have to go to this pharmacy to pick them up.
Pre-COVID, I had to take my handwritten prescription, but now I don't.
But those you'll see, again, these are only for Schedule II controlled substances. That's your hydromorphone, which is Dilaudid, your oxycodone, your morphine, fentanyl, hydrocodone, your amphetamines, your methamphetamines, your barbiturates, things like that. Schedule IIIs,
Isn't marijuana moved to Schedule III now?
In the process.
I think it's still a Schedule I, but I think
They passed
How is it?
I think it,
Federally, it's still a Schedule I?
yes,
they're in the process of
yes. I think federally it has to be acknowledged before it can be ever moved. And right now, states have decriminalized it, and you can have all of these things. But federally, it has to be accepted on a federal level for it to be moved. Schedule IIIs, you'll see, are your codeines, your barbiturates, your ketamine is a Schedule III. Those are all examples of those. Schedule IVs, your tramadol, your benzos. You'll see those with your Ativans and your Verseds and your Valiums. And then your Schedule Vs are any prescriptions that are dispensed, that are, they typically usually contain like an opiate or a stimulant, but they are not that in and of itself. Like, it's not just, here's hydromorphone. It's one of those things that it'll contain a little bit of this, but or they're usually in low doses. The Controlled Substance Act separates medications into 5 different ones that we just went over, but please know, Schedule I has no recognized medical uses. Again, LSD, MDMA, all of those things. Schedule II have a high abuse potential. The two things with those, they can't be called in over the phone, and your hard prescriptions must be turned in within 72 hours. Meaning you can't hold on to that prescription for 4 weeks and then go get it filled. Your Schedule 3 through 5, or excuse me, 3 through 4, the medications can be refilled with 5 or 6, up to 5 times in 6 months on an original prescription. So that's when your doctor can write 30-day supply, 5 refills. So that gives you a 6-month total. And then your Schedule 5 medications, there is no limit. They can just say, those are the ones that, you probably have on a regular that you can call your doctor and be like, hey, I'm out of this. And I'm like, all right, I'll phone it in and I'll put you a 12-month supply on. That is at the discretion of the physician. Typically, unless it's some like actual treatment drug that's for like chronic and long-term use, you don't see anything beyond a 6-month refill, just because they need to make sure that everything's going right. Because if they write a 12-month refill and then you don't go in for a year, and you're having some adverse reactions or effects, or it's, doing blood pressure or whatever, and they don't check on it, they're guilty of the issue. So
Is like hospice care change how like 72 drugs work? No, so like it's still like
no,
like you're trying to be
the thing with hospice is they're their own pharmacy as well, so they can write the prescription and then fill it themselves. So you're talking about like the IV morphine or liquid morphine and stuff like that. Yeah. They are their own little subsector that they kind of are a one-stop shop and they can do it all themselves. We are empowered to administer many different controlled substances. Yes to all of those, your fentanyl, morphine, Versed, Valium, and Ativan. You have to understand, if you try to steal narcotics, you will be caught. I know it's happened. Many services around us have had in the area in general, not necessarily around us, but in the area, have had people, whether it's empty vials and take them home and then put saline back in it or whatever, you will get caught. That is a federal offense. You can serve some major prison and jail time and fines depending on what it is and how much it is and whether you plead or not. But they do not take that lightly. You can lose your numbers. You can lose a lot. You can lose, the service can lose their numbers. The DEA and FDA make frequent requests from us just to make sure our stuff's in order because we carry so much and we use so much here that they're like especially after my last medic class that I had 6 of my providers would go through it. Though, you know, you're your new medic, so they're just out there just candymanning it, giving it, and they were like, we don't do that, man. You've had 2 refills of fentanyl within 30 days. And there's 25 fentanyl in each thing. We're like, that's sus. Like, you're right. So I had to talk to a couple providers and be like, we have other medications besides narcotics. We have things like Torin. Yeah. So don't just think that people aren't watching. They is. When you have a controlled substance log, there needs to be the date of the medication administration, patient name, medication name, medication dose, and the medication strength. All of that has to be on your form somewhere. On ours, we do how much is administered and how much is wasted. So if we draw up 100 of fentanyl and we only get 50, it'll show 50 micrograms is administered, 50 micrograms is wasted. Because obviously you're not going to be like, I'll hold on to this till later. It's not a multi-dose vial, and I don't want any of my people walking around with 50 mics of fentanyl and just be like. So we have to document how much was used and how much was wasted as well. Oh, right there it is. Administered and wasted. The name of the person administering and wasting the medication, and there always needs to be a witness, all of the time. You guys need to get familiar with this thing. Hello? Corey, will you go grab me a narco form out of the multi-purpose room? I'll pass it around so you guys can see it. Medication names, they can go by many different names. You've got chemical names, generic names, trade names, and official names. Very rarely are we using the chemical. That's the one like a cat walked across your keyboard that, you know, you can't really pronounce. We're not using that one. Typically, we're using one of these 3, generic, trade, or official. Thank you, sir. I'll pass this around so you guys can look at it. You'll be utilizing these when you're here, and you'll just know the information that's on there and what ours looks like. Again, your providers may be different, but that is what ours looks like. Since you'll be doing primarily some of your ride time here, you'll need to know how ours work. Anyways, back to the names. Chemical name, yeah, that right there. If you ever are like, I'm going to give you some ethyl 1 methyl 4 phenylisonepicotide hydrochloride, I'm going to go. Most people aren't going to be using that, but it is the precise description of the medication's chemical composition and molecular structure. You can see those numbers indicate how much of each one of those chemicals it has combined in the substrate. Yes, in our PCR, but we do we double document all narcotics. Because we have on the back end where we track it, we staple that usage form, and each medication has its own piece of paper just to say if the FDA or DEA would come here and they're like, where'd this fentanyl go? And go, Casey used it, Justin was our witness. This was the run number. This was the day. This was the patient. And then if you need to look at the PCR, the run number's on the top. Then you have your generic name. That's a weird word, mark delete. Abbreviated form of the chemical name of the medication. Generic medications usually have the same therapeutic efficacy as the non-generic and are usually less expensive. So what this is this is after the 10 years and the patent has expired, I go and get Travis's formula and like, I'm gonna make this myself. I can't call it Adderall, but I'm gonna make the same thing as Adderall. And we're gonna call it amphetamine salts. So instead of it being Adderall, it's amphetamine salts, and it's the same thing. I just make it cheaper because I don't have to do a bunch of advertising. I don't have to do any of that. And most providers are going to be like, hey, this is the same thing and cheaper. So after that 10 years of use, I don't have to do any advertising, and they just write it for whatever. Because like, you want the generic or do you want the name brand? Most people will be like, which one's cheaper? Generic. Write me that one. And I didn't have to do any R&D. I didn't have to do any research. I didn't have to do any advertising. I had to do nothing. Travis's company did it for the last 10 years. So after that, I just make my own formulation of it and call it less. It does the same thing.
Are there any that are, I guess the brand names, like, that are better?
Allegedly,
Noticeably better.
allegedly, you know, some people, there's some people that it's the placebo. That it's just, the generic doesn't, like, I have to have true Advil. Okay. It's the coating. There probably is something out there that, you know, has something in their formulary that's bound different that reacts a certain way. I don't. Huh?
Like it might be a little bit more efficient.
Yeah, and the efficacy of time or use or duration or how it's released might be better, but I don't know. And all that's going to be relative to the patient. You know, just like you can take lisinopril for 10 years and then have a reaction to it because there's so many NDCs of lisinopril that you get a different NDC from a different manufacturer. You can have like instant angioedema from it. So obviously there's something out there changing something. Your trade name is the copyrighted name designated by the company that sells the medication. Trade names always have a capitalized first letter. Your generic names are all going to be lowercase. Your chemical names are going to be lowercase with numbers. So if you see numbers in it, it's most likely, and a bunch of hyphens, it's most likely the chemical name. But if you see a like this, where the D in Demerol is capitalized, that is in fact the trade name. Trade names are proper nouns, so they will be capitalized. It's like your name. Then you have official names that are always followed by a USP or an NF, denoting the official publication. This is usually the same as the generic name. It just has USP after it. So if we get rid of this USP, what is it? Huh? Trade, because you have a capitalized first letter, right? You add USP after it, now it's official. And if this was lowercase, then it would be what? Correct. That is how you work through those lists. Huh?
Yeah, so in the book, it lists that as generic. If you took the USP off, it lists it as generic.
If it was lowercase.
It's got it up.
They're wrong.
They're wrong. What does it start at the beginning of a sentence?
No, they've actually got it like listed out before.
Well, that is wrong.
It says Demerol is the trade name for it.
Fair enough. Name, generic and trade. Classification. When you're doing your drug cards, these are all things that who had my drug cards the other day? You still have them?
No, they're put on the paper.
They're still in there, do you know? Yeah, if you don't mind. I will pass around a couple of my drug cards so you can see what works for me. Your miles may vary. But you'll need to put all of these things on here. On your drug cards, you'll need the name, generic, and trade. The classification, is it sympathomimetic? Is it narcotic? Is it an analgesic? Whatever the case might be, would be class, an antiarrhythmic. Mechanism of action, how it works. Does it potentiate beta-2 receptors? Does it potentiate beta-1 receptors? Is it an antagonist to beta-2 receptors? How does it work within the body? Indications, when we would give it, right? Pharmacokinetics, side effects, and adverse reactions. Contraindications, what would be happening, why we wouldn't give it, whether it's, did they take Cialis 12 hours before and now they're having chest pain, do we give nitro? Potentially no, right? Things like that. Dosage, what the normal therapeutic dose is, or administrative dose for us or your service. I will say, I know at some point in this class, somebody's going to argue with me of saying, that's not what our service does. Cool. You're going to write down what your service or our service or a combination thereof both does. But very rarely am I going to be giving 2 milligrams and your service be giving 10. Usually there's that threshold of 2 to 4 or whatever that we're relatively close. So just learn yours within reason. You tell me you're giving 50 milligrams of morphine, we're going to have a conversation. And then special considerations. Those are, how does it interact with pregnant patients? How does it interact with children? How does it interact with people with certain conditions or in certain culture sets? So, someone yanked it. Yeah, figure out who yanked those things. Medications come in many forms: liquid, solid, inhalants, sprays, and suppositories. Does anybody in here carry nitro spray at your service?
We used to, but we don't anymore. Good,
Yeah, we used to here too, and it was like the whole Dumb and Dumber thing. They went to spray it, and sprayed the wrong way. Spray the provider.
We had firefighters using it.
Huh?
We had firefighters using it.
Yeah. Yeah.
Cost difference.
There is a cost difference, but there also is a use out of one spritz and done.
Yeah.
You get a lot more use out of it. But again, it was kind of like that whole crazy guy next to him. And then now you're over there and the patient's like, oh shit, he's dead too. And, it's one of those things that with liquids, even your vial medications and stuff, and nitro spray, I don't want to say it is a, I don't want to say it's a suspension. It's not a suspension, but that stuff can kind of flip. And nitro is so reactive to sunlight and heat that the efficacy of it, you can't, measure it with a spray because it can become separated or diluted, or the heat can do it. So if you use it, cool. It's just one of those things, like you say, you got people that abuse it or people that don't know how to use it. And typically the pay through the tabs work just as well. Suppositories, I will not be playing with anybody's booty hole in the field that I don't know. Usually you'll see that with children, with some stuff. There's a couple anticonvulsants up there that actually are rectally administered. Something like that's usually prescribed to the family, and they do it. We don't carry anything in the field for that. Yes, before someone asks, you can put oral glucose rectally. If you do that, you're fucking weird. But the thing, it can be so absorbed in any type of membrane. But I would just much rather use like D50 or something. Creams, lotions, patches, and lozenges. Yeah. Typically, we're not going to see many of these pre-op. Now, the patient, I don't know how many times we've gone to a nursing home in this county and be like, our patient's unresponsive and they have an altered mental status. You have 3 fentanyl patches. I would also be unresponsive.
We had one when I was at New Chapel. They had, it wasn't fentanyl patches, it was, fentanyl patches. She had like 40 of them on. It was hiding them everywhere.
But wonder why they're unresponsive. Yeah. Liquid forms, you have solutions that will carry. We usually aren't carrying that. Don't know anybody that would carry suspensions. I don't know really anybody that would carry the rest of it. Well, I guess you can have.
We have
Do you? For like children.
time. We've never.
I'm the firm believer if you can get over the counter, I don't need to carry it.
I don't
That's
understand
just
why we
me.
can't give it. Like EMTs cannot give it.
Yeah.
I'll give it to my kid at home.
I guess methylprednisone would technically be a suspension because it's a reconstitution. Cyclodrol. I don't know any syrup of Ipecac, if anybody still has, they don't make it anymore, but if they have a rendition of that, or activated charcoal, that's technically an emulsion.
The slide metal is suspension or a solution?
It's a reconstitute. It's, I guess, by definition, it would be a solution, but I can see how it's a suspension. Same, because it's a reconstitution. I feel like with the proper dose they put it would equate to be a suspension though, because it would be equal parts. It's not really suspended as much as it's reconstituted. Suspensions are the ones that you have to shake really good. You know, you'll get your kid's antibiotic or something. Those are suspensions. That they'll separate in the fridge or whatever. And you have to shake them real good so they don't taste bitter. Or get all that powdery layer on top of it. Most common in EMS, ampules, prefilled syringes, and vials. I would say 90% of our medications here are vials. Another 9% are prefilled syringes, and then we have epi. There's your ampule, which single dose. Typically, obviously, epi 1-to-1 you'll see it in if you carry the ampules, if you don't carry the multi-dose vials. And then fentanyl can also come that way. You'll see if you've never seen an ampule, they have the scored line across the top on all of these. Has anybody never experienced working with an ampule in here, like breaking one and using the medication? Let's see if I got one back here. So they're kind of neat. They work off physics. So this is an ampule, big ass ampule of that. These are all live medications. Don't lick them, don't taste them, don't do nothing stupid. But this is an ampule. You can see right here on the neck, it's got a scored line right there. So what you'll do, everybody's seen an ampule over here. What you'll do is you'll take a towel, your shirt, whatever, just so you don't get cut. Hopefully you have gloves on. You grab the top of, you make sure all the medication is out of the top of this first. You'll take it and you'll break it. Breaks right off. As you can see, it is not a clean break. So don't be like, hey, you'll cut your finger. The good thing about these is this. You turn it upside down and nothing comes out because physics is fine. Now, if you shake it, it'll come out. But if I'm going down a road, you can see the surface tension still doesn't. On these things, you have to use a filter needle. Why? Glass, right? So you can't just take a normal needle that's already on a syringe, you know, like our 3 cc's that just come on there. Those are not filter needles. Don't use that. You have to take that off and use a filter needle. And then you'll draw that out of it. your levofen can come in this, your fentanyl, your epi, things like that. Obviously, again, if I shake it, it'll start dropping out, but it still doesn't pour. It's just physics and surface tension. It is quite fun. But again, what you'll do is you'll hold it upside down, you'll stick your needle inside, and you'll draw it out. And again, you must use a filter needle on this. You can see here, very jagged, so do not touch. Where is the charge? Oh, that's right there. These must be disposed when you're done in a sharp container because they are sharp. Do not put them in the trash. So those are ampules. Pre-filled syringes, probably what a lot of you are familiar with either if you've ever been through a Help the Medic class or just using this stuff. They screw in on the back end. They have this little hub that when you go to take the yellow piece out, the green piece comes with it, and you have to separate the two and put the green piece back in. I'm sure we're all familiar with that. The boxes are usually color coded. So if you're, depending on how you work and where you work, somebody will be like, hand me the light brown box or hand me the epi. They'll tell you the dosage and then the ml on there, and on the front of the box, the dosage is easily broken down for you. It'll say like 1 gram, 1 ml, or 10 milligrams, whatever the case might be, and you can break that down on there. Tubex, very rarely do we see this. We do have it on some of our morphine and Dilaudid medications that you need a carpujet or some type of inducer with it. But they are pretty rare. Single dose vials are probably really common with those. That's what most of our medication comes in. But the dosage can vary by manufacturer. Like right now, I've got 2 different dosages of Versed. One's 5 milligrams in 1 ml, and then 2 milligrams in 2 ml. So you need to read your vial to see what it is. Same thing with my ketamine. Some of it is 50 in 1 in a 10 ml vial. And then some of it is 101 in a 5 ml vial. Have to read what your dosage is. When we draw out these medications with the vials, if we have 2 ml that we want to extract, we take our syringe, we fill it up with 2 ml of air, stick your needle in, inject the 2 ml of air into the vial, hold it upside down, retract your needle to the bottom and let go. And it should auto retract with most of the pressure that you've injected in there. All of those that are not multi-dose vials, if they're not multi-dose vials, you need to inject the same amount of air or the same amount of medication that you want. Does that make sense? Okay, and we'll go over all this. We'll do the hands-on stuff. Your multi-dose vials vary from constitution and drug manufacturer. They're often less expensive than other preparations by unit. So like a multi-dose vial of epi costs me $187, but there's 30 doses. If I bought 30 ampules at $8 a piece, that's $240. So by unit, it is cheaper, but it is more expensive. And the problem with multi-dose vials is most are only good for up to 30 days after that initial puncture has happened. So that means now I have to use 30 doses of epi in 30 days. Solid medications, pills, powders, capsules, and tablets. The only pills or solid medications that we carry here would be our Plavix and our Nitro. Oh yeah, aspirin. Good call. Inhalants, we'll see those in our bronchodilator medications, your albuterol, your Duoneb, your Zopanex, all of those things. Your sprays, Nitro, again, I don't know many services that carry that anymore just because, like was stated earlier, the abuse of it, just fucking around with people. I mean, because that's the thing, I can walk up and be like, hey, Nigel. And he's just, okay, I'm gonna take dirt nap now. There's nothing you can do about it. You have people fucking with people, or again, just misuse and getting it on you, getting it in the air, spraying it on you, any of those things. Forms, again, not commonly found in EMS are these. We do have the transdermal nitro, that is technically a cream put on a piece of paper. But other than that, I don't know of anything else that we would use that would fit any of those categories. These are a lot of your over-the-counter things. Antagonism, you need to know these terms. It is very important. So if you see antagonism, antagonist, any of those words, it's the opposition between two or more medications or two or more things in the body. So if I have an opioid antagonist, what does that mean? Huh? It means it's going to fight against the effects of opioids. It's going to oppose the effect of opioids, which would be Narcan, right? We've already went over black box warnings. Bolus, and I got in a big debate with Derek Barrett about this, his medic class. A bolus is different than an infusion. A bolus is a single, often large dose of medication. Now, we incorrectly use the term bolus when we're giving fluids, but while it is a single dose, it is usually over the course of several minutes to hours, right? You know, if we bolus 500 ml of saline, we're not doing it in 12 seconds. It's taking 5, 10, 15, 20 minutes. By definition, it is a single dose, but to me, a bolus is when we're giving pushes or something. Contraindications, medical or physiological conditions that present in a patient that would make it harmful to administer a medication of otherwise known therapeutic value. Now, when we start doing drug cards, the biggest contraindication word you are going to see is hypersensitivity. That is a bullshit term for meaning they don't like it, they have issue with it, or it causes some reaction, but it is not life-threatening. So you'll hear people say, I'm allergic to that. What does it do? It makes my big toe itch while you're taking it. Like, that doesn't impede your airway, and obviously me giving you this medication could save your life, so just sit there and do this, and I'm gonna give you this medication. Or they say, my throat swells shut, we're not gonna give that. That's different, right? So you need to look at your level of contraindications. Now, this is typically like, they have, they're septic, right? Like, we know they're septic, they've been diagnosed with sepsis, or you have the ability to, see that they're septic, and we need to RSI them because their breathing is inadequate. We know at that point we're not going to use succinylcholine because it causes a huge potassium shift that's going to make their sepsis worse. That would be a contraindication. Controlled huh?
I have a question.
Okay.
I had a lady that was having a massive MRI one day, and she only had one kidney and adamantly refused to take the aspirin. And I got to Floyd, and Dr. Connor basically shoved it down her throat and said, just give it anyways. So, like, what does it do with the kidney? I know it can't, like, process it as well, but still.
Yeah, I mean, people with one kidney have to be, and usually that is a ibuprofen thing. But all NSAIDs can be, and like aspirins and stuff, can cause circulatory issues or metabolism issues within there. So people have been told, especially that are on one kidney, don't take this, and they don't understand that don't take this as regularly, not a one-time thing. And what we have to look at is, well, at your funeral you can have your kidney and not your heart, or we can give you this, save your heart, and we'll work on your kidney later. Like, that's the conversation that needs to happen. You can have an undamaged kidney at your funeral, and your heart can be dead, or we can address the heart issue, and we'll worry about your kidney, your dialysis, some other fluids, some treatment, whatever, on that side of things when we're done. But if we don't fix your heart, we don't give two shits about your kidney. Like that's what it, but I mean, these people have been instilled from their doctors and their physicians and their specialists to say, don't take this, this is bad, you can't have this. And that's more on a regulating basis of, oh, my hip hurts, I'm gonna take ibuprofen. No, now I'm gonna take Tylenol because it's metabolized in my liver and not my kidney. And that's just that's what's been instilled in them. Cumulative action occurs when a drug is administered in several doses, causing an increased effect. This increased effect is usually due to the quantitative buildup of the drug in the blood. So that's when we just push dose stuff, or we give repeating, I'm going to give 50 mics of fentanyl, 50 mics of fentanyl, 50 mics of fentanyl. If I give those 10 minutes apart every time, the half-life is 45 minutes. Those values are going to start compounding. That's what a cumulative effect would be. Depressant. Besides EMS, that's a medication that decreases or lessens a body's function or activity. What's a depressant that we use? Most of our medications are depressants because they're usually antagonists to something. Ketamine is a depressant. Fentanyl is a depressant. Morphine is a depressant. Now they can have dual roles, so they are an agonist for this, but an antagonist to this. Most of the medications we use are to lessen pain, lessen heart rate, lessen breathing rate, like all of these things, right? We're reducing the effects of what your body will react to. DEA, they're a fun group of individuals that have a really good sense of humor. That are the federal agency that is responsible for enforcing the Controlled Substance Act. So anything that is a controlled drug, they have full realm of. Anytime they can walk in and be like, let me see all your shit. Let me see your storage. Let me see your housing. Let me see your overflow. Let me see your kits on the truck. Let me see everything. Let me see your usage logs from the last 10 years. They are entitled to all of that. Why are you smirking over that? I can't help that. I didn't write the book. Enteral is the administration of a drug via the GI tract. So that's going to be mostly what?
Medication.
Pills and liquids, right? Or suppositories. Anything that you swallow is going to be that. FDA, they're responsible for the approval of medications before they are made available to the public. Again, back to that whole Purdue thing. They had someone that worked for Purdue Pharma for, I think it was like 12 years, some crazy shit like that, that when they started going down this opioid thing, they miraculously got a high-level job at the FDA. And their FDA approvals went through like that. Crazy. Habituation, physical or psychological dependency of a drug. Goodbye.
So that'd be for like people that, well, I can't function unless I have my Xanax because I get.
You usually see these in your Xanaxes, your Adderalls, your stimulants, typically where you see these. Hypersensitivity, again, is a reaction to a substance that is normally more profound than seen in the population, not sensitive to us. It just means that they have a rare reaction. A majority of these people didn't have it, but everything is going to have a hypersensitivity because they would have to test it on all however many billion people there are in the world. Not going to do to know what it is. So that is their BS term for saying something else. Idiosyncrasy, an individual reaction to a drug that is usually different from that seen in the rest of the population. So that would be an example of I gave nitro and their blood pressure went up, that would be an idiosyncrasy.
Like kids who get hyperactive on the
Yes, like I'm one of those people. My older child is one of those people that you give Benadryl and they're fucking white, where most people are like, I'm gonna go to sleep. That would be an idiosyncrasy. Indication is a reason to give a medication and a drug that which has been proven at that therapeutic value. So it's saying, I have this, you should give this at this dose. That would be an indication.
We have a guy in Jeff, maybe you can explain it because the doctors didn't care to.
Must have been McKnight. Anyways, go ahead.
It was. So, Isley James,
He's a SWAT doctor, did you know?
yeah, he's on my team.
Yeah, I'm sorry.
He took some passenger seat and talked about PA.
Cool. That's crazy because he won't talk to Mike. He will now. Anyways, go ahead. I hope he listens. We should all show up. Hey,
So obviously, okay, then we have a kid who abuses prescription narcotics.
Okay.
And I've never seen this before. Have you?
No.
So when he takes these pills, like I think it's press fentanyl, he gets amped up like he did meth or cocaine. And we give him Narcan, and he stops. I've never seen it.
so typically what's happening in these press pills is they're mixed with stimulants in it. I know up here, like, are they blue?
They're perk 30s.
That's
Yeah.
what they're advertised. Are they blue
No.
I've
or
never seen
red
it.
or white? So what we're seeing out of the blue press pills up here is that they're mixed with caffeines and meth. So you're getting both of these effects of that. And with these opioids, because there's still these opioids in them, with those receptors being triggered, that is enhancing the effects of those stimulants. And then when you can remove those receptors off, because you're using those opioid receptor sites to initiate that connection, once you can get those receptor sites off, the efficacy of the drug is no longer.
Like this drug makes him act
He's like on Vassal.
Yeah,
Yeah,
that is what we're seeing. I have lawn darted so many people up here in the last probably 2 months just because of these press pills that it's crazy.
I mean,
Because before when we were seeing these press pills when they first got out, I mean, people would be like, I normally take a point of head. They would take one pill and they're fucking dead.
well, just
And now it's just fucking.
because what I'll do is I'll handcuff him and I'll just give him nasal Narcan and he's golden.
Mhm.
Like a completely different person.
Yeah, I'm from what we've learned, because I deal with our SWAT team and stuff up here in our narcotics team just to see what's like what they're finding in these things. That would be my guess. I could be completely wrong, but that's what it seems like it's doing. That like they'll do a test sample on these press pills and they're popping for fucking everything. It's not just an opioid. It's not just meth. Like they are popping for 4 or 5. It's a rainbow.
They took our fentanyl test kits away because we have some smarties working with it.
Yeah, that would be my guess. Parenteral routes of administering medication into the body without going through the digestive tract. That's going to be all of your IV, IM, IO, typically where we're seeing most of our medication administration. Your IN, your inhalations, all of those things. So if it's not a pill and it's not a liquid and it's not going down their food tube, it is parenteral, and that's what I would say 95% of EMS medications are in the field, if not more. Because again, like here, it's your aspirin, and I know some companies still carry Benadryl tabs, liquid suspension, Tylenol, and stuff like that. Potentiation, this is what I was talking about earlier. Enhancing one drug's effect by another. Benadryl is one of my favorite potentiators, which is something I learned over the years that has amazing effects with typically narcotic medications, where I can reduce the administration of narcotics, but enhance the effects of the drug. And I use that on one of like those situations that, I've heard from some of the companies south of here that, we shouldn't be carrying certain medications. Those are typically by the same services that can't carry those medications, so it's kind of weird. But anyways, that, we're going to throw people into relapse or this or that. Well, again, I can assure you, none of our people here just pump people full of fentanyl. I know all of our people ask you, have you had a dependency issue? I'm about to give you a narcotic pain medication. A lot of them refuse, or some of them have ailments that it doesn't fucking matter. Their tib fib is poking through their skin. Toradol is not going to help. That is typically when I'll give some Benadryl and give a low dose of fentanyl, so they'll still feel relaxed. They'll feel better, but I'm not causing that. I'm not trying to throw them into a dependency issue. And that's usually where I can call the doc and be like, I want to use Benadryl for something other than what Benadryl is designed for, but this is my reasons why. And they're usually like, go ahead, that's fine, that's smart, whatever. But again, sometimes, there is no way around it. We have the ability here to use stuff like ketamine, but again, typically ketamine can do one of two things: really work or really throw them into a rage. And the last thing that I want to do someone that's got some type of actual traumatic injury is throw them into a rage, because now they're not keeping that appendage still. It's making my job really difficult and their condition a lot worse. So, yeah. But everybody's got an opinion. Refractory patients or conditions that do not respond to a drug are said to be a refractory drug to the drug. Sometimes that's because of time. Sometimes that's because of other medication. So a refractory drug that we used to carry here that we no longer carry is flumazenil, Romazicon, one of those things. You'd see that we'd use that on benzo overdoses. The problem is, when someone withdraws or is acutely taking off benzos, it throws them into a seizure. What do you need to address the seizure? Benzos. So now you're in a pickle, because I've given the Narcan of benzos. Now I can just sit here and do this with benzos, and nothing's going to happen. Because that Romazicon or flumazenil that I gave is blocking all those benzo receptor sites, and it's going to have no effect. Not fun. Side effects: unavoidable, undesired effects frequently seen even in therapeutic dosages. Again, that's your headache with nitro. It's just part of it. Your heart matters more than your headache right now. Deal with it. A side effect of epi is tachycardia. A side effect of adenosine is slow to no heart rate. That's what it's supposed to do. That's what the drug is designed to do. Sometimes, I give adenosine and the heart rate come back. That is a side effect, an undesired side effect that I might have. Stimulant, a drug that enhances or increases a bodily function. Cocaine is a stimulant. That is a stimulant to the kidneys. Not to the body, but to the kidneys. Synergism. Again, this kind of goes back with the potentiator. You can't really have a potentiator without synergism, right? But it's a combined action of two drugs. The action is much stronger than the effects of either drug administered separately. So usually when you have a potentiator, you're trying to achieve synergism. That is the goal. You're trying to take these two things, mix it, and make it really cool. Now, we're not mixing it in the fucking syringe, here you go. But you're trying to give those two things. Therapeutic action, the desired intended action of a drug given in the appropriate medical condition. That's why we all have those starting thresholds or those starting doses, and we have those max doses as well. Let's say if you can't achieve a therapeutic level by this, there is no therapy like that. It is. So that is your dosages. Tolerance, that comes from prolonged use of certain medications that, again, we've seen that with the whole Opana thing. They start people on 5s, and then, 5s wouldn't do anything. They bump them to 10s, and then 10s wouldn't do anything, and then they bump them to 20s, and then 40s, and then 80s, and then 160s, because their body is building a tolerance and they're forming a dependence. Untoward effect is a side effect that proves harmful to the patient. Any questions? If not, we'll reset. Um, Lipitor. High cholesterol medications. That's the enzyme in small fractions. Grapefruit juice inhibits that enzyme.
That's why y'all were there.
They got
So, grapefruit juice inhibits the metabolite CYP3A. That is only small intestine. And then your pills are going to be enteral. The digestive system, you can't produce that metabolite over balance.
I think they. Yeah.
But wait a second.
And those things. Something like that. My wife makes them, they're little bites. Like, stop it, take it, easy, go here. Morning, Jack.
It's $3.
Anything on it?
That's really. Two.
Sorry. That tracks. Do you mean? Someone trust me to run it. Prospect. Oh my God. Prospect.
Prospect?
Yeah.
That's what I do. Hello, everybody.
It was wild. It's like, here's no thunder.
Yeah, I would guess.
They have
They're
that-
out there toward Brownsboro.
They have that one picture. Way the fuck out.
Yeah. That's out.
Like,
That's out
bordering.
of,
Yeah, they have a truck that's bordering County Union Ocean.
yeah. Mhm. There's also one that's way out there off Shelbyville.
That truck is implemented.
Today you probably got on the Friday that said that.
No, he did.
Oh, here's just fucking.
It was a Sunday.
Good fucking.
It was a Sunday. I think it was just, I think that girl was short.
That the face on.
Well, whenever they fuck off, that shift change too. So like if they stay too long, do whatever they do, and so all the Eastern trucks get pulled over to other areas. Shit, out of population for hours.
Yeah.
And it never gets back on track again. And it ruins the whole day. 'Cause, I mean, even after all of St. Matthews, to cover Anchorage and then to all metro trucks we get hit on runs.
I heavily debate going into it on time. I'm gonna be there.
I guess it should be dashboarding now.
Yeah, I'm back. Said, hey, you're temporarily gonna be back at station 2 for the next 5 shifts. I'm like, freaking leave me alone. He's not on our shift anymore.
Again? Jeez.
Five of you that need to address your lab situation need to. That would be
On it.
Urban, Sterling, Corey, Travis, and Jesse.
Yeah.
I'm just waiting to get my schedule back. I don't know what my new schedule is gonna be, so that's why I haven't done anything yet.
I guess you're gonna have to pick a day and tell them when you have to have a day off to trade the day.
Yeah,
You make things super complicated. Yeah, just take a straw. I will go over this right now. Everybody can get out a pen and paper real quick. If you plan to ride here, which I'll assume right now, considering taking, most of you are going to want to. All Kentucky EMS sites have been turned down by K-Beam, so for now, we're still working on it. We're paying a $700 storage fee right now, but it's gonna be weeks to months probably before the K-Beam thing up. All right, so the 23rd, I have one opening. It's at here. And the hospital has an 8A to 8P and an 8P to 8A. '24 has 2 spots open here. And 1 spot open at Scotty RPM, 8P to 8A. 25th has 1 spot open here. And both spots open at the ER. The 26th has 2 spots open here. 1 PM ER. The 27th has 2 spots open here. And 1 spot PM ER. The 28th has 2 spots open here.
We have class that day.
For the Friday.
Yes, we do have class that day, but it will not be a full 8 hours. So if you want to ride here after class, you can sign up for that day. 28th has 2 spots open here and both spots in the ER. 29th has 1 spot open here. Both spots in the ER. 30th is full here with Eric and Joe, but both spots are open in the ER. So that just gets us to July 1st. So those are the availability that are not on that calendar, but are here. Anything I need to clarify for anybody or go over a certain date again? Obviously, you can see this on Platinum, but I'm just letting you know now. These are the spots that are open that are not signed up for on there. You need to put it in our group meet of the day you sign up for, so I can put it on the calendar. So that is an extra week and a half of ride time that we will start.
The lab is gonna be the phlebotomy lab, right?
Correct. Again, before we leave today, we will go over those sheets one more time. That'll be the last time. This one's a short chapter, but. All right, pharmacokinetics is the study of how medications enter the body, reach their site of action, and then become metabolized and eliminated. It also determines the duration and intensity of the medication's effects, which we know is what? Efficacy and half-life. Where'd he go? You pooping? Pharmacokinetics is dependent on the body's various physiological mechanisms that move substances across the body's compartments or membranes. Again, we have different metabolization sites. We have the liver, you have kidneys, you have heart, you have lungs, you have all these things where these things might be metabolized. Well, not the heart, but you know. They can be further broken down into 2 broad categories based on energy requirements and other classifications. This definition you'll need to know. Mechanism is referred to active transport if it requires energy in the form of ATP. An example of this is the sodium potassium ATP pump. Again, you have to have energy for that.
Which group I signed up for the day, but if the day I come off shift, so would I be able to, since it's just 8 hours, 9 to 5 instead of 8 to 4?
For lab?
Yeah.
Go ahead and sign up for it, but I don't know what time they're like full lab closes at 6, so you should be able to do that.
Yeah, because all the dates are the day after.
You can come back 3 back in county available.
Carrier-mediated diffusion are large molecules that are too large to pass through a cell membrane. Those are helped across by a special carrier protein. Can be an active process known as active transport, or passive process called facilitated diffusion. We should remember all of that from A and B. Active transport is going to go against the gradient. Facilitated diffusion is going to go with. Based on the body's ability to move substances in and out of cells. Again, passive transport does not require energy. You should know that osmosis and diffusion are the big two, and you also have filtration, typically found in your kidneys, spleen, and liver. There are 4 factors that affect the concentration of the medication. That include the absorption, distribution, metabolism that we will refer to as biotransformation. That is how that medication is broken down within the body, and then how it is eliminated. Medical absorption, progress from its pharmaceutical dose, form to the biologically available substance that can pass through or across tissues. So it takes it from its whole being, broken down, and how much is available within the body for use. Things that are going to affect absorption are going to be the solubility of the medication, the concentration, pH, where it is absorbed, the surface area of where it is absorbed, the blood supply to that site, the bioavailability of it. Can I clarify any of those things on that slide for you while we're here?
Bioavailability.
How, so drugs, like obviously when they metabolize the protein, it's going to be how much after that metabolism and that breakdown occurs is actually, hang on, where's that? So if we give, I'm gonna use this random a number. We give 20 milligrams of something, right? Some of that is going to break down. It depends, and this is what the half-life of that medication is, what the duration of that half-life is, the therapeutic dose of what that half-life is. It's all going to be dependent on bioavailability. So adenosine is a great example here, right? Adenosine is something that has to be slammed quickly because the half-life is seconds, right? But if I don't get a therapeutic dose, which our initial dose of adenosine is 6 milligrams, right? If I only give 3, that's going to change the bioavailability of that medication because I didn't give a therapeutic dose. And if I slow push that, that's also going to change the bioavailability of it because it only lasts seconds. So if I slow push this medication at a half dose, the bioavailability is going to be moot because before it ever reached its designated area, the half-life's gone. The medication is metabolized and it's broken down. So that's going to determine what the bioavailability is.
Is that also going to the routes that we give certain medications and the doses that affects it? Or
Yes.
does it give them, I mean,
Yeah, if you go IM over IV, right, more of it's going to be broken down or it's going to take longer to absorb because it's not going directly into the bloodstream. And then what muscle did we give it? That's why a lot of people use the aft muscle, because it's so big, there's a lot of vasculature there, right? And it's more surface area for it to go into, and then it's, you know, obviously if there's more surface area, it's going to swell the muscle less, so it's going to hurt less as far as long term. Obviously the needle and the medication can burn, but beyond that, you know, anything over an ml of injection needs to go other than the arm, because it's going to take up that, it's going to start moving those muscles, and it's going to be painful because, you know, in reference, if you look at your arm and you look at your ass, there's a lot more muscle here than in your arm, and that's just science, right? So, but yes, that's all going to take place into there. You can see here the differences between like different routes. So IM is obviously going to metabolize a lot quicker than something that's sub-Q. It's going to take effect a lot quicker, but it may not last as long because it's absorbed quicker, it's metabolized quicker, and it goes in quicker. But you can see for the circulation, it's going to hit circulation a lot higher just because of the blood supply to muscle versus fatty tissue. It is what it is. Just like with IV, we take a pill, it takes a half hour for it to be broken down and metabolized in the body, right? With an IV, it can have instant effects because it's going where? Directly into the bloodstream to be metabolized. So that's why if I give you 100 micrograms of fentanyl IV, or you take a hydrocodone 7.5, 500, right? You're going to have instant effects of the fentanyl IV, and it's going to last a little bit. But if you take a pill, it's going to take a lot longer to take effect. But when it does, you're going to have a longer duration of the effect because it has to be metabolized and broken down and go through different systems. It's not directly into the bloodstream. Here's your route and rates of absorption. You can see your sub-Q and your oral are slow. Your topical, intramuscular, and intranasal are moderate. Then you get down into your endotracheal, your inhalation, sublingual, and all of those are rapid. Your IO and your IV are immediate. Now, you have to remember the medication. This is the rate of absorption, not the effect of the drug. So the rate of absorption could be immediate, but if the drug is designed a certain way, it may not take effect immediately. Like there's certain things. Solumedrol is a perfect example, right? Solumedrol, we give IV or IM, right? That's immediate or moderate absorption. But even if we give it IV, it's going to take tens of minutes to start working. Like seeing effects of it working. It's working right away. But for us to see effects can be 30, 45 minutes. There's a lot of patients that we'll give it to that we won't see that transformation in the patient condition because of how long that medication takes to make its effect. But the rate of absorption is immediate. It immediately starts working. Distribution is the process where a medication is transported from a site of absorption to the site of action. Things that affect that are obviously going to be your cardiovascular function, blood flow in that region. Do you have any storage reservoirs? Is this something that you take daily? Or is it something that, we're giving that's just a one-off? Obviously, these people that take daily medications have that tolerance and that efficacy level built up in their body. So it's just a sustainment at one point. That's why you'll hear a lot of doctors say, hey, you need to take this for 2 weeks, or you need to take this for a week before it has its full effects. That's because when you first start taking a medication, you're going to get it and then it's going to eliminate it. You're going to get it, it's going to eliminate it. But as you start this regimen, it can't eliminate as quick as you're going to be taking it. So it's going to build up that threshold in the body. Biotransformation is the process by which that medication is broken down into different chemicals for the body to use. It can either be made into more active or inactive form, or made water soluble for elimination by the renal system. All that is going to depend on what metabolites it takes for that biotransformation to take place and how long it's meant to. You know, and this is, you'll see this, that this is why there's different dosages typically in the geriatric population, because they don't have the same renal function as a normal functioning adult. So we'll half dose a lot of those patients just because those levels take longer to be eliminated. So you're going to have a longer effect of those medications. So two terms that you need to know are prodrug and first pass. That has to do with biotransformation. And that's the process in which the metabolites or metabolizes the medication to be in its active form, or deactivates the medication to prevent further action. Can I give any explanation on either of those? The prodrug is going to be when it turns it into an active form after it's metabolized. You see a lot of this in your extended release medications. It's enhancing and making every time that it's metabolized more active in the body. First pass means after its initial round of metabolism and absorption, it starts becoming less and less active. And most drugs that we administer are going to be based off of first pass. We're not here doing long-term. We're trying to get immediate effect right now to solve a problem or make a problem better, right? So a lot of us that we're going to, fentanyl, all of your pain medications are going to be first pass. It's just, it becomes less and less active each time that it's metabolized or goes through that round of circulation. Very rarely are we giving them extended release, but some of your bronchodilators and stuff like that are going to be prodrug. The more it's in the body, the more available it's going to become and the more active it's going to be. It just depends on what substrate we're giving it through, and it also depends on what the target site for that medication is. Easiest way to differentiate the two is prodrug means it's going to make it better. Like prodrug is going to make it more active. First pass is going to make it more active. So this is how Valium breaks down. All of that, you'll see it transform into this. You'll lose a couple carbon molecules and they'll break off. You'll lose a chloride molecule and then it becomes into here. I don't know how it breaks down, but it lost. Now it absorbed another oxygen molecule and broke those hydrogen apart because of binding it. Elimination refers to the movement of a medication or its metabolites from the tissues back into the circulation and from the circulation into an organ for excretion, whether that be the liver, whether that be typically the kidneys or the GI tract. It's going to enter somewhere to be eliminated. But your two big ones that we'll do are metabolized through the kidneys or the liver. The body excretes medications through numerous systems: renal, respiratory, hepatic, biliary, and GI. Again, the administration route is going to be highly dependent on how it's excreted, and then the target of it as well. Any questions on any of those? Many factors are going to affect the rate of elimination. Big one is the medication's half-life. Accumulation, just is there a built-up threshold within their body? And the other things that we're going to go over on our drug cards are going to be onset, peak, and duration. Onset is how quick that becomes metabolized and starting to take effects in the body. The peak is at how long does it take to reach its peak or maximum therapeutic level. And the duration is going to typically be double or 4 times the medication's half-life, depending on how it's broken down in the metabolism. Obviously, if we have hypoperfusion or poor circulation, those medications are going to be poorly eliminated. That means it's going to, all of those things, the half-life and the duration, the onset, the peak, are going to change. And that's why in that geriatric community, who typically have cardiovascular disease, or they're chronically hypotensive, or they have renal insufficiency, you're going to see longer effects, longer onsets, longer peak times, and significantly longer half-lives because of those that hypoperfusion. Confusing question.
No, that was actually answering a question. That was good.
Because if we have poor perfusion, it's not getting to the liver as quickly, it's not getting to the kidneys as quickly, it's not getting to these areas of metabolism as quickly and the areas of elimination as quickly. So they're just staying freely available in the circulatory system or the tissues longer.
So is that something like you're taking into account during like traumatic shock situation? Like you assume it with the geriatric patients that they're not going to metabolize well, but when you're out in the field, something that is more acute, that something you're taking into account. Like if I'm having to push this medication, it might take
Yes.
3/4 as much to be as effective as a full dose.
100%, especially in your traumatic situations that you're going to experience like hyperperfusion, like due to shock, or you have a septic patient that is in shock, or septic shock, distributive shock, whatever might be going on, right? That doesn't necessarily mean I'm going to double my dose because that's going to make it worse in the long run. But what I need to realize is, I know that if I give this medication to you right now, I should see some type of reaction in 30 seconds to a minute, right, with this medication. But I know that if you've got half a liter of blood sitting on the ground and, you've got systemic failures within your respiratory system or whatever, might be, especially if you've got some type of splenic lack or liver lack or something that is suspected, I know that metabolism is not going to take place as quick. So especially, like ketamine, where it's metabolized in the liver and stuff, if I need to RSI, I know that my 30 to 45 second of downtime prior to my paralytic administration might be 2 or 3 minutes because it's going to take longer for this drug to metabolize. So that's 100% something that you need to take into consideration of. I know I should still have this effect, probably going to take longer because I don't have as many vessels transporting that medication to where it needs to go, or that target site of metabolism is not functioning properly. So the part that is going to be responsible for the same dose of medication that would normally be metabolized, but everybody can help, right? Same concept. If I say, I need all of you to get up and flip this room, it's going to happen in X amount of time. But if I say, this side of the room stand against the wall, this side of the room do the same work, it's going to take this side of the room twice as long to change everything around because you have half the amount of help. Same concept. Pharmacodynamics is the study of the mechanism by which medication dosages act to produce biochemical or physiological changes in the body. So that is on a molecular level. Medications act in 4 different ways. They can bind in a receptor site like Narcan. They can change physical properties of a cell. They can combine with other chemicals in a cell. Or they can alter metabolic pathways. Receptor site binding are usually protein molecules that allow certain chemicals to bond or bind at those receptor sites. Again, Narcan is a good example of that. It binds to those opioid receptor sites and doesn't allow anything else to occupy that space. You have agonists that will bind and cause it to initiate the expected response. Or you have antagonists that do not allow the receptor to initiate the expected response. So Narcan would be a what? Opioid antagonist, because it is not allowing the opioids to bind there. It actually kicks the opioids off those receptor sites because it has a greater affinity, and it does not give that opioid the expected response that we would get. That's why they come back real pissed off. The mechanism of action, classified by the receptors. There are multiple receptor sites for different organs. When we go in, like you'll notice once we get back into pharmacology after today, you'll notice that it's broken down into neurological, ACS, all of those things. When we get down and we're in those specific groups, we will go over those individually. All those details of beta receptors and how they got key locks on them will be in the book. Your therapeutic index is the difference between the minimum effective concentration and the toxic or toxicity level. So if my LD50, I'm just going to use straight numbers that aren't going to make sense in most cases, but just for purposes of doing this. If my LD50 level is 50 and my therapeutic level is 20, what is my therapeutic index? 30. That's how much room you've got to play with that dose.
It uses Narcan if they want.
So you can see there's a wide range of concentration for that therapeutic dose. So anything between here and here, on the grand scheme of things, would be acceptable. That's why some patients we have to do repeat doses. We don't start with an LD50, like right below the LD50 dose, just because of the effects it has on the body. Because obviously, the more we give of anything, the worse it is on the body, right? You don't know how those people are going to metabolize and all of that. There's some people that, you'll give 100 micrograms of fentanyl to, and they are fucking out, right? And there's some that you'll have to give 2 or 3 repeat doses to have that same effect. But you just have to know, like, I can't give more than 500 micrograms of fentanyl. At that point, we have a problem. That's why on our trucks, we carry 4. Alleviate the problem. Drug potency and efficacy. Both of those are the relative amount of a drug that is required to produce the desired response. That is going to be patient dependent. It's going to be ailment dependent. Obviously, if I give 50 micrograms of fentanyl for a stub toe, it's going to be pretty efficient, right? If I give 50 micrograms for a femur fracture, you might as well just hand them an ibuprofen and a Tylenol. Which one works better, right? It's going to depend on that patient and the ailment. Factors to consider in a response: the age, body mass, gender, and environment. I don't know what that other word means. Anybody know what that word means? Let me Google it. You're on your phone. Google it.
The person's social environment.
What?
Environment setting.
Huh?
Environment or setting.
What are the different setting?
Environmental or social environment.
Okay. I guess if you hang out with a bunch of druggies and you do a bunch of drugs, you're gonna have less effect on that. Sure, we'll go with that. Time of administration, genetic factors, psychological factors, and that psychological factor is a big one. Sometimes we have the ability to calm those people down. You have some patients that are just in a state of excited delirium that a lot of their organ systems are, I don't want to say shut down, but unreserved. That if I normally give 2 milligrams per kilogram of ketamine, that's going to knock all of us out. We're all going to be stoned, right? You have someone that's excited delirium, we double that dose to 4 milligrams per kilogram to get them to calm down, not put them out, calm down. And that is all psychological. Obviously, your pediatric patients, your special considerations, pediatric patients, geriatric patients, and pregnant patients. This is a big one that usually, we can understand there's dosage differences here. We should understand there's some dosage differences here just because of their ability to metabolize medications. This is the big one that we forget about or we don't put as much research into, is those pregnant patients that not a whole lot of us, admittedly, am saying rightfully so, look into the fetal development stages of medication it's all right for an adult, it's all right for a pediatric, but it's not all right when there's fetal development taking place. And that's something that a lot of us are not good on and have to reference a lot when we have medical issues with a person that is pregnant that is not relative to the pregnancy.
We also, this is something my dentist mentioned to me, like pregnancy and lactating increases your metabolism. So like you metabolize drugs a lot faster. Like I was getting some work done and they had to like
Redose a lot.
redose a lot when I was.
Yeah, your metabolism's hyperactive because you're trying to break down for 2 things, right? But then there is the consideration of what is this going to do to fetal development? Can this fetus sustain this medication right now, or will it harm the fetus? That's the bigger thing that we go off of is, can I give this drug because we're in the 2nd trimester of pregnancy? What is it going to do to that fetus? Will it stop its heart rate? Will it cause some birth defects? Will it do something? And that's something I still have to reference that I'm like, can't see. I just don't. It's one of those special populations we don't come in contact with every day. I should do a better job on researching that. I'm guilty of it as well, but that's something that we do need to take into consideration prior to getting medications that you might want to stop. Obviously, if it's life-threatening, mom is priority. But that's something that you need to consider. Even something as simple as Zofran needs to be taken into consideration.
We have pregnancy classes and under cards.
Yes. And some medications will typically say no information on pregnancy. Some drug companies aren't like, this is medicine. Pediatric patients are not little adults and must be dosed accordingly. How many of you in here are familiar with Hantevi? It's a good cheat system for pediatric stuff, or you can just remember pediatric doses or reference your protocols. Hantevi does help on a lot of the main medications, your epi, your atropine, your D50s, fluids. A lot of your medications become weight-based, and you use your fingers and saying it's this old and this many pounds, and it helps you know what your administration is supposed to be. Due to changes in development, metabolism, and all of that, they're more specially dosed due with their body surface area. You can use a Broslow tape, or you can obviously use your protocols or contact medical control. How many people in here still use a Broslow tape or some rendition of it? What did the rest of you guys use?
CD wheels.
Same concept.
You don't have anything.
That's fine. What do you guys use at AMR?
We have some Roswell tapes hanging.
What do you guys use? Where are you at? If you don't know how Broslow tape works or a PD wheel, Broslow tape, you start at the head and wherever the feet land, you use that certain color coordination. They land in yellow, you pull out the yellow bag in your PD bag. Is how it's designed to work, and everything you would need for that kid is in that, like from ET tube size to whatever, and it'll tell you on that tape what the medication dose for all the main medications are. Some companies pay to have the PD tape done for their specific service to say, hey, these are all the medications we carry. So list all the medications here. And then there's some, like we here, just use a generic one for, your main medications of epi and dextrose and adenosine and atropines and, TXA and stuff's not on there just because we don't have to. We're kind of in a pickle if we do. But a lot of the main medications are on there. They land in blue, you grab a blue bag. Pink, makes it just easier because it's usually a high stressful situation that you can just grab a thing and everything you need for that age group. Factors in geriatric patients that can lead to altered pharmacodynamics and kinetics, obviously decreased cardiac output, decreased renal function, decreased brain mass, and honestly, to me, decreased body mass as well as muscle mass, which are all has to do with your circulation as well. So again, here our kind of rule of thumb is if they're over the age of 65, we start half dosing unless. Total body water, body fat, serum albumin, which we're not going to know, but they decreased, and then respiratory capacity. For pregnant patients, they have increased cardiac output, an increased heart rate, and an increased blood volume. In those same pregnant patients, they have decreased protein binding, decreased hepatic metabolism, and typically a decrease in blood pressure. So obviously that protein binding is important because that's how a lot of these medications are carried across certain membranes or into metabolism sites. A lot of medications, like I've stated earlier, metabolize in your liver. So if you have a decreased function there, it could either take longer or not take its effect as quickly. And then your blood pressure is just gonna have to do with how quickly is it circulating the body and delivering to those receptor sites. These are your pregnancy classifications. Category A, show no risk. Category X is completely contraindicated. And then everything in there. You've got B, that there's no evident risk in humans. Or there have been studies that have not demonstrated risk in the first trimester, and there are no risk in the last trimester. And animal studies have demonstrated, but animal studies have demonstrated risk. C, risk cannot be ruled out. Animal studies showed risk, but there's no adequate studies in pregnant women. That just means it was bad for animals, haven't tested humans. D, provide evidence that there is great risk in human and animal testing, but benefits could outweigh the risk. Again, it's dependent on what is going on. And the X just say these risks are going to probably show fetal detriment, so it's either don't give it or it has to be for the saving of the mother. Because obviously without the mother, they're both at risk. Any questions on any of that?
Drugs, category C.
Yeah, that's a lot of yours will fall in C, like there's animal, human testing, and it's your miles may vary, unfortunately. You're gonna need about 100. Now that's saying that you're breaking all the dextrose down. D5 is one part, D25 is one part, D10 is one part, D50 is one part. And I recommend doing it that way because they each act differently. Administration of medications. Before administering any medication, you should know what your protocols are and know what everything that goes along with that medication is. The route, the dose, and risks that could be involved. I've been doing this for over a decade now, and I still, if it's anything beyond like Zofran and things like Toradol and things like that, I still will show my partner what I'm giving just as a check and balance. And that's something that I feel like everybody should get in the habit to, because everybody can make medication errors. A lot of these vials look the same. You know, I can order Zofran one time and it's in a green bottle with a green lid, or a green label with a green lid. The next time I order it, it could be powder blue with a powder blue lid. But you also know what else is powder blue? Benadryl, terbutaline, thiamine, all of those things. So it's very easy to grab the wrong drug in the patient. Each order or protocol should contain the following: the medication desired, the dose desired, the route in which you're going to give it, and the rate in which you're going to give it. Now, most of our medication rates are IVP, but we will do some drips, we will do some boluses, we will do some drips, we will do some infusions, all of those things. And that's where you'll have, 250 ml per hour or whatever the case. But most of it's IVP, just IV push, meaning it's given at a normal push rate. You have slow IVP, you have fast IVP, you have all of those. The 6 rights of medications, you need to know all 6 of these. Now, some of this is kind of ruled out for us, like the right patient. Typically, we know we have the right patient. Some of this is kind of for the ER setting that happens way more, the hospital setting in general, that happens way more often than people realize, that they'll come in and be like, all right, we're here to give you this. I'm like, thank you, Mr. Williams. It's like, my last name is Brown. And they're like, fuck. And they're like, it's okay, it's just Zofran. They have to correct that. So typically our patient is right in front of us. So the right patient is pretty self-explanatory for us. But then we have the right medication. Again, going back to that, medications come in many different forms, colors, vendors, NDCs, all of those things, and then the same medication. I think I've got some in here. This is the perfect example. This is furosemide. This is also furosemide. Same medication, 40 and 4, 40 and 4, same dose, different color top, different color label, different shape bottle, but they're the same thing. And you'll have this, mimics our, now granted it's got a green, will mimic this, same bottle, same shape, same size, different medication, different color top. All of this can vary on manufacturer, NDC, all of those things. So the right medication is huge for you to at least verify and read. Right dose, what do I want to give? What is the proper dose for this patient? What is the proper dose for this condition? Right route. That happens more often than you think. Here, we carry some medications that are IM or sub-Q only, and that people will end up giving IV. Not great, right? What do you mean? Okay. Right time. This is kind of big in your hectic situations like your code by giving it the right time apart. Not necessarily the right time of day, like I can only get Zofran afternoon. It's more of, am I giving this on the right schedule and the right dosing increments at the right algorithm, depending on what I'm doing. And then the right documentation. All of this needs to be documented. As you've seen in my narratives earlier in class, I will put not only the concentration dose, but the volume dose. I will put 4 milligrams and 2 ml of Zofran, because I think that shows I knew that I gave 4 milligrams and I knew how much liquid was in this syringe. I think that's the proper way to do it, but your miles may vary. Documentations on narcotics. Most of your, I assume you guys do down there, have a section in your PCR that, yeah, so that you'll have to document certain usages within your PCR. I already went all over these. Again, always triple check to make sure you're doing the correct dose and the correct medication. Again, these primary routes that we will use, enteral is through the GI tract, so that means it goes down the little food tube. And your parenteral routes are any other medication other than through your food tube. IM, sub-Q, IV, IO, transdermal, buccal, inhalation. And please remember, just because it goes in the mouth doesn't make it enteral. Buccal and sublingual are not enteral by definition. Question?
You said buccal is not.
Yes, it is.
By definition, because you're not swallowing it. It's being absorbed through the vasculature. What I was going to say is, and that's why I said by definition, some medications will end up dissolving in your mouth and you'll swallow that. And that can be enteral because you're still like swallowing what it produces. Some of them you plant in your cheek and they will absorb through your tissue. Those are not enteral. So it depends on how it is being, I guess, distributed after it's put in. So some of those can change. That's why I was saying by definition. PO, sublingual. So sublingual always will be, because we end up swallowing that. Buccal is the one that may not always be, because we all know that some of those fentanyl pops and stuff that they'll give that will plant in our cheek, we're not necessarily swallowing that as much as it's being absorbed through there. So buccal is the only one that I will put with an asterisk and say it depends on how the delivery of that is being done. The rest of those will always be entered. PO is in the mouth, oral. You got OG and NG. Do you guys have any protocol down there for OG or NG administration? This is typically more of a critical care or flight setting that they might be doing those. Like we'll place NGs and OGs here, but we won't do any medication administration through them. Sublingual, we should know is under the tongue, not on the tongue, under. Buccal is in the cheek. Rectal is obviously self-explanatory. Parenteral routes, topical, intradermal, intranasalar, sub-Q, intramuscular, IV, IO, ET, sublingual injection, inhalation, umbilical, and vaginal. Topical medication is absorbed through the skin. Onset is variable due to the varied rate of absorption, thickness of the skin, placement, security of it to it. Intradermal is injected directly into the dermal layer of the skin. Intranasal, we should know. Sub-Q is into the sub-Q layer. That's lower. Your limit on sub-Q is 2 ml. And when we do injections in here later, you'll realize why. Is anybody in here not done? I mean, I don't know how Kentucky's in, but is anybody in here not done an IM or sub-Q injection? Okay. So you go tell Taylor I need her to go to the store and buy a bag of cuties. Thank you. Actually, fuck that. Service can pay for it. Actually, she has her own car. I need some cuties. Please. That's it. IM is going to be placed into a large muscle mass. Again, onset of medication is not as rapid as IV, but where IM is all muscular with muscle, you have circulation, it is fairly quickly, just not near as quick as IV or IO. IV is obviously our most common route. However, we have the high potential for adverse effects. We have high potential for necrosis. We have high potential for infiltration. We have the potential for doing art lines. And if you ever get an art line, we don't just send it and push it anyway. You remove it. I might let someone start an art line on me later so we can see the difference of what it looks like in an IV. You'll know. Thank you. Who's here? Who just walked in the door? Open up the door. ET, medications can be absorbed through the pulmonary capillaries. I don't care. Okay. That's a crazy lady from. However, the rate and quality and quantity of absorption are independent factors and very variable. So obviously, if we do ET, this patient's intubated by definition, right? If this patient has pneumonia, bilateral pneumonia, are they going to have good absorption? No, because you have all those capillaries in those alveoli that are just surrounded by fluid or mucus, right? So that is going to be a variable that is going to be immeasurable to us of how much is being metabolized. This should only be done in a pinch, because too much fluid can do what? Drown, right? If I'm giving my epi every 3 to 5 through an ET tube, What's happening? We're just filling with fluid. Now, some of that pressure is going to help disperse that, but, you know, that's why they don't let you give bicarb through an ET tube. 25 ml of fluid. So you're not great, right? Sublingual injection, rare. I've never seen this done in the field. Not saying that it's not. I've never seen it done. Because if I can't get an IV and I can't get an IO and I can't intubate the patient, we're having a real fucking bad day. And the last thing that I'm worried about at that point, and any medication that would epi or something like that can be done IM. So I don't know when this would be done. I'm sure your book gives you an example possibly, but it's when we administer an injection directly into the sublingual capillary network under the tongue. So when you go like this, all those vasculature underneath there, you try to hit that. You just jam it in there.
Actually,
Yeah, not great. And there's a lot of nerves under the tongue that if for some reason you do give a medication there, and you say to them, and I thought like this, because you've just neutralized the nerves in their tongue. And then they can't sleep on their back because in the tongue, it's a great time. No thanks. IO, we should all know what that is. Inhalation, aerosolized medications. Umbilical, they're done through the umbilical vein. Typically, they need a catheter. I've seen this done in the field one time on a baby who delivered. Not a fun time, but it can be done. And then vaginal, I don't know any time that us and EMS are going to be playing with anybody's meat curtains, unless it's for delivery. Yes.
On umbilical vein health, since the umbilicus, the vein and the arteries are flip-flop for oxygenated and deoxygenated, is that not going, would you not put it into the umbilical?
No, because it's still high pressure, and you're giving it, and the umbilical is still supplying from the mother, so it's being circulated from the mother through there. Now, if it's cut, then you'll still do the umbilical vein, because it's still a pressure thing and a bleeding thing. Preparation, consider dead space, consider reconstitution. Remember when you're withdrawing from an ampule, you need a what? Filter needle. Some medications you may have to mix. We have to mix several here. And then skin preparation as well, whether it be for nitro paste or transdermal patches if you carry them. Always take me aside. Sterilization and disinfectant and antiseptics, whether it's of the patient or the vial, multi-dose vials, you always need to clean the top of the vial prior to puncturing the vial. Never recap a needle. Read the slide. I recap every needle. Is what it is. But don't do that. Immediately dispose of your sharps in a sharps container. I'll tell you, like when I RSI and I still have medications in there, I will draw up and I'll never remove my needle from the vial. I'll leave my needle in it. That way, if I need to redo it, my needle's still in there, everything's still clean, and I can just reattach and then draw back out. I do that on 90% of my medication. I'll use the shit out of needles, but I have them on any of those multi-dose vials or those single-dose vials that still have medication in there. That's how I'll do it. And then you don't have to worry about recapping it because it's protected in the glass vial. Administration of medication, perform a thorough assessment, always obtain vitals before any medication is given, unless it's cardiac arrest. Pretty much give the vitals at that point. Make sure you ask for patient allergies. The biggest question you can ask is, I'm allergic to XYZ. What happens when you take XYZ? Again, risk versus reward. They tell you they get rashes on their toes, okay, they're gonna itch. They tell you their throat swells shut, probably not gonna give it. Determine whether, when you contact medical control, determine whether the order is consistent with your training and scope of practice. If you're ever told to do something and you're not comfortable doing it, don't do it. Simple as that. Confirm the order by repeating the medication and the dose again, with the volume and concentrations changing so much, that can be done in drips. You can say you want it in a 250 bag and 8 milligrams in a 250 bag. That would be your volume and concentration. But typically with vial medication, you just want your dose. And then obviously your route of administration. Is it IM, IV, sub-Q? Those are our main, or IO. Write down the order and time of order if you have the possibility. A lot of us use our monitors, as generic markers or whatever that, you can reach over to your monitor and hit a timestamp that it marks it for you. Select the proper medication. Again, check the name. When it's first selected, check it again when you're drawing it up. And again, Derek can vouch for this. I've been doing this for over a decade, and I will still hand him my vial and show him my syringe and say, this is what I've got. Because if I show him a vial of, 2 milligrams in 2 ml, but I've got a syringe full of 10 ml full of liquid, he should be like, where'd you get that other 8 ml from? I'm like, oh shit, you're right. Or I might say, this is diluted in a flush. There's 2 ml in here. I only drew an ml up. You can still see there's liquid in here. The other stuff is diluted in here. Having that check and balance just to make sure you're good in the smell is good. Check for cloudiness, particles, discoloration, and expiration date. That's big on fluids. If you don't have a climate-controlled bay where your ambulances are held, a lot of those medications can go bad quicker than the expiration date, especially fluids. If they heat cycle, in the winter, if they freeze, that's also real bad. Anything that freezes, you're supposed to discard of. Confirm that order. Make sure that if there's any concerning dosages or calculations, when we get into med math in a few weeks, half of you are going to be flying right through it, and the other half are going to want to kill me. Because math to me is super simple and fun. So math, you might hate math, but medical math is big on our end now coming into the paramagician role. Again, do your 6 rights. For documentation, again, drug dose and volume. That's what I do. 4 milligrams / 2 ml. IV. I don't necessarily put the time. In my timestamp on my PCR, I do, but not my narrative. And then make sure, I don't care if you give the medication at the hospital as you're pulling in. You bring the monitor with you and you cycle those vitals at least one more time prior to handing off that patient. Never give a medication and not recheck vitals. Ever. Other routes, again, that we use, we went over transdermal, also known as topical, sublingual, all of those other things. Anybody here carry an MDI on your truck? No? And I never understood it. I know some MDIs have that adapter piece that you could, attach to it and reuse, but still, that's like a cross-contamination thing. But, it's kind of, even though it's got 30 doses in it, it's like a one-time use, if you will. Rotohaler, those are like those little pucks that, they'll open, they'll breathe in, and they'll slam it open, and then it'll distribute, and they'll say, you got 27 administrations left. And then SVN, small volume nebulizer, those are those peace pipe looking things. It's an IO gun, that's an easy IO. That one is drill-based, battery-operated, proprietary battery. You can't rechange a battery, you gotta buy a $1,200 gun every time you wanna do it. So I boycotted them and I don't use them anymore, but it is a good device when the battery works. Problem is, people go, more than they use it. And that is the type of battery that it goes until it doesn't. So you can be half administration and it die. And if there's not enough power and torque left, you're halfway in sitting there and you have to just be like, to get it in. That's the alternative. Got plenty of, huh? Yeah, it happens. Her face did the same thing. Oh. Yeah, that right there. That's the alternative. We use SAM IOs here. They're not the best, but as long as your hand works, they work. It's true. We use humeral head for the primary site, tibial for the secondary site. Unless there's a lot of articulation or a lot going on, then just we'll go tibial just for the sake of, there's a lot more movement around the head, so you can knock it out a lot easier. So it just depends on what's going on. For the love of God, don't fucking conscious IO people just for the sake of having access. You are a Neanderthal, and you should have it done to you. As someone who got IO'd in their medic class, not a pleasant experience at all. I will say the administration of the actual needle, while unpleasant, is not awful. 1/10 of an ml of fluid will make me want to kick a baby as far as I can. It is excruciatingly painful. I have disarticulated my knee, and it was about as equally as painful. It is a very unpleasant experience.
I've heard the old sternal ones are even worse.
I'm sure. Someone
Fucking sprint.
chest pumped you in their chest, and now you've got 10 needles in your chest. You're sitting there like the archangel. Like, yeah, I'm sure that is painful. So yeah, just if you have to have access and it's life or death, you do you. But you better be able to articulate why you did a conscious IO. There's plenty of ways to sedate a patient prior to that conscious IO.
And so you're gonna let him get the number off his printer real quick.
For what?
Did you say any donors?
Yeah, we used the last toner.
Yes.
Same thing up front, we're running out, we are out of black and blue and yellow up front, so we'll need some refill cartridges. Because I'm about to print probably 1,000 pages today.
I'll make this go back.
Sounds good. Yeah, if you don't mind, did you check the one in that already?
We got a notification on that.
Okay, yeah, so if we can bring maybe an extra black for me, that would be appreciated.
Okay.
Because the front hallway, yeah. Thank you. Any medication error can have a much greater effect, and any medication error needs to be documented, correct? Yes. Please remember, all weight-based drugs is done in what form or unit of measurement here? Kilograms. That means you have to convert from pounds to kilograms. And if you don't, you're going to double your dose at minimum. So, paramedic must modify the adult administration techniques for pediatrics, obviously. We need to understand that there's different dosages. Thank you, I'm hungry. I appreciate it. You can do that. Children usually don't cooperate, especially when you get next to them with sharp things. Feel free to try. That's pretty much more of a, if you don't have to do it, don't. But if you have to do it, power through it. Usually, these little things have the strength of Hercules, and it takes like 2 to 3 providers, like one to hold the torso down, one to hyperextend their arm, and one to do the IV. And then it takes all 3 people to get a splint on their arm so they don't immediately do this or reach over with the other one. Super fun process. Most of the time you can't be like, it's only going to hurt for a second. Like, oh, okay. No. And it's a fun time. So good luck. Power do it. That's why a lot of services still do carry those oral suspensions and oral administrations of Tylenol or ibuprofen or Benadryl and things like that. If you have a service that has a high volume in ped runs, it makes sense. We don't carry any of this stuff on the truck. We kick around the idea of Tylenol, but at the same time, it's one of those things that by the time we get to the hospital, it's still not taking effect. So it's just another formulary that we have to carry that I'm not messing with. But if you have a high number of ped runs, your service may have a lot of those oral suspensions or administrations. If you do have that, obviously don't put it in a little cup or just dump it in their mouth. Measure with a syringe without a needle. Draw it out. Intramuscular, use the smallest gauge needle appropriate for the medication. Now, while that might sound dumb, you're going to realize as we get into this, the viscosity of each medication is significantly different. And, you know, we can give epi through a 23 gauge needle, no problem. It's a very good solution. You try to give Ativan through a 20 gauge needle, you're going to beat your 23 gauge needle, you're going to be here tomorrow still drawing it up. And then administering it is twice as fun. So you're going to have to understand the viscosity of your medications when we do that. If we have any Ativan back left there, or any expiring up front, I'll let you try to draw it up. Not a pleasant experience. That stuff's like syrup. Length of IM needle will not exceed 1 inch, except in adult size adolescents. Once you get to adults, they will not exceed 1.5 inches. Children who have walked for over a year, you can do the gluteus or dorsal gluten area. Walking develops those muscles. So obviously the longer they're bigger, the older they are, the longer they've been walking, the bigger those muscle groups are. Older children, deltoid, butt, vastus laterals, those are all common areas. Technique is the same for an adult. Sub-Q is the same, obviously. Goes under or in the under the dermal layer into the fatty layer. Yep.
Is the max different than an adult? 2 ml is a bit different from.
Typically 1 in pediatrics if it's in the arms or whatever. Typically with those kids, you're going to want to go to cheeks, or their arms are pretty fatty and fluffy anyway, so they can hold it, but it just depends. IV is going to be the same. Use caution on any medication, because it can have a greater impact. I have to take this phone call for 1 second. Hello. I do. About the blood coolers.
The administration, same as an adult, you're not gonna want to slam your things, but we're be conscientious of your vasculature, and how fragile it may be. Depending on your size of the angiocath that you use, you have to think about the pressure that's going, like the fluid going through is going to be a lot higher through a 22 gauge versus an 18 gauge. So if you're using an 18 gauge on a child, it's more power to you. But let's think about the size of the child, the size of the vasculature, and the viscosity of medication, and also the amount of medication that you push. Rectal administration, it's not something that we really do, but a lot of times with kids with seizure disorders and stuff, you will see parents will have home medications for rectal something, maybe something that they have administered prior to your arrival, like diazepam for seizures. But that's not typically something that we are going to do.
Five.
Beautiful.
Yep.
Just to give you.
It's only bad when you click it.
Emily, has Jade started down there?
No, not yet. I was looking for like, cause you usually go new people to meet, and I don't have her. I don't even know. Maybe she said like, yeah.
Jade, she kind of, her mom's paramedic in County. I taught her EMT class.
Really?
I think she's good about it. I think how everything's went down Oklahoma was shitty. And her partner should have been fired.
Who is her partner?
Was Daryl.
Who?
I don't know the last name, but everybody fucking knows who Daryl is.
Daryl?
Yeah.
Yeah, she's good at Bull County.
And if you hear her on the radio, you know it's Daryl. Because she has the most Kentucky mixed with Texas accent you'll ever hear in fucking.
She's Josh Darnell's.
Radio, your show.
She's
I
what?
won't say
Josh Darnell, that works in Washington County.
Yeah.
His baby mama.
Wait, I have a question about pediatric IOs. So I've done 2 pediatric IOs, one with a 2-year-old, one with a 3-month-old. They've never been successful.
So their bone density is. So what happens typically is we apply too much pressure when we're going in, and what we do is it's a lot of compact, but not compact, spongy bone. We put that pressure extra off the bone when we're going in. So it'll shear the bone off and actually crack it where it separates, and then it's not stable.
I drove like I drove, and then I just need it.
Yeah, so that was either the wrong placement, or it was too much force going in and cracked it, or it was too deep with the needle and it went through and split it in half. The red one, it's they don't have a whole lot of compact bone; they have a lot of spongy bones, so it cracks a lot easier. All right, we're gonna try and get through this other one before lunch. That way, when we come back, we're gonna do a chapter of, at least a chapter of what we were supposed to go over today. We can get some of that out of the way, and then we'll do IV and all that stuff for 2 hours or so. Okay. We will need to document stuff on Platinum. I'll give Tyler at lunch that he needs to open a lab for today. For the IV and IM stuff that you will need to, each one of you, I'll go over that later, we need to document it, and then we'll go from there. Sound good? Yeah, perfect. Thank you very much. What did we just do, chapter 3? I'll go to chapter 5. $19. It'll be, I feel like it's. Everybody back? Welcome. Yeah. You didn't pay attention to the class on the phone anyway. Am I wrong? I was. Huh? Fluids. Your internal environment of your body. Total body water is anywhere between 60 and 70% of your total body weight. Water is one of the most abundant substances in your body. Intracellular fluid is about 45%. You can see 3/4 of all water is found in intracellular compartments. How much of your systemic circulation is plasma?
45%.
And how much percentage of plasma is water? 92 to 96%.
Runs to being a 3, that's right.
Extracellular fluid, 15% total body weight. Interstitials around 10, and intravascular is around 4.5. Yeah. All right, electrolytes are chemicals that take on an electrical charge when placed in water. Common ones we'll deal with are those 4 listed there: sodium, calcium, potassium, and magnesium. Again, I know I've shown ringers in here before. Your ringers contain all of those. Plasma light contains all of those, plus a few more. And then obviously your saline is just going to contain your sodium. Sodium is your most abundant cation. Cation meaning what? Huh? Positive charge within the body. Negatives are what? Anions, right? Sodium helps with the regulation of sodium. It's primarily done in the kidneys, in the renal tubules, and the loop of Henle. Little fun fact. What?
So that was a
They asked that. Test.
What?
That was asking on one of the many tests I put on the computer.
The loop of Henle or the renal tubules? All of it?
Yeah.
Sodium question.
Alterations in sodium balance can lead to water retention, and respiratory and cardiac alterations. Obviously, if you have a sodium imbalance, that leads to a water imbalance, which is going to lead to a right-sided or left-sided heart overload, which will be affected by preload and afterload. You have calcium, which is also a cation, necessary for the structure of bone and teeth. We know all that. Helps in the coenzyme for clotting, hormonal secretions, helps membrane permeability, and obviously needed for muscle contraction. You do need to know that calcium is regulated by the parathyroid gland and the renal system. Alterations to your calcium can lead to bone and muscle weakness, as well as, again, to respiratory and cardiac alterations. The old potassium necessary in the conduction of nerve impulses in not only your skeletal muscles, but as well as your cardiac area. Other important functions include glycogen storage in the liver and maintaining electrical neutrality in the cell. It is extremely important in the conduction of cardiac rhythms and muscle contractions. That is one of the first things that we look at dysrhythmia, when we have dysrhythmias or arrhythmias on patients when we do our labs, is look at the value of the potassium. And lo and behold, any alterations to potassium can lead to respiratory and cardiac alterations as well as muscle weakness. See a pattern. Lungs and heart are dependent on all of these things. Any alteration goes bad. Magnesium is it's mostly stored in muscle and bone. Highly important energy source for the sodium-potassium pump, which controls what? Where do you find your sodium-potassium pump mainly? Heart. Well, as other muscles, but mainly your heart. I'd venture to say any alteration of this is also going to cause issues with your cardiac or respiratory system. Magnesium is mainly used for relaxation of smooth muscle as well as increasing cardiac cell stability. Main thing we use magnesium here for is either arrhythmias or breathers. Where we'll do.
What's the point of using mag to stop the reaction?
Like a pregnant patient?
Yeah.
Because what is your uterus? What type of muscle? Smooth muscle. So it causes, it depolarizes the cells to become. Do we need to go over diffusion again?
No.
Facilitated diffusion?
No.
Facilitated diffusion is what? Sounds like we need to go over it. Jesus Christ, the Latter-day Saints. It is still moving from an area of higher concentration to lower concentration. It just needs a bodyguard or a helper to carry the shit there. Specialized protein to carry it. But it's still going from higher to lower concentration. Both of those are what type of processes? Active transport. That requires energy, and it is moving across a semi-permeable membrane against the concentration gradient. So remember, that is like the one dude that forgot, you know, the dude told his wife, hey, you should bring a jacket, it's gonna be cold in here. Cold. And then we get in there and it's fucking cold. So he has to go back out to the car to grab a jacket. So he's walking against all of those people that are coming in. That is active transport.
That's really great.
You like
I
that?
will forever.
Most iconic example is the sodium-potassium pump, which maintains the balance of sodium and potassium in the human body. Here's where you're all going to get confused again. The concentration gradient. Hypertonic is a state when the solute concentration of a solution is higher on one side than the other. That will cause the cells to do what? Good. Isotonic is when they're equal, which will cause the cells to do what? Hypotonic is when there's more water than there is solute, causing the cells to what? We got her. Those pages are in your book. Plasma, 92% water, contains 1 milk. Formed elements, respiratory. They deliver oxygen and remove CO2. From a nutritional standpoint, they deliver substance for cellular metabolism. From a regulatory standpoint, they deliver electrolytes and hormones dispensed within the body. Again, we know that blood has within blood, it contains what type of cells? Huh? Red or white? We can carry both, but when they were talking about defense or removal of cellular debris, which ones do that? You have your phagocytes, your neutrophils, and all of those things, correct? Remember, we have our different blood types. A and O being your top ones, with B and AB being your less common. I know I asked this question before, but I don't remember. Does everybody know their blood type in here? No? I donated blood once to figure it out. Like my personality, I'm B positive. Huh?
I'd be negative.
You're B negative? Then you have your RH factor. 95% of the population is positive. Then you have your negative Nancy's with the other 5%. That's supposed to mean you're passive aggressive and you just say the nice stuff. Not going to go into this. This is what chart, what page is this on in your book? Okay, you can study that at home, highlight your chart, and make sure you need to know it. This just says what type of antigen it has. So it can receive A, cannot receive B. Cannot receive B, or doesn't have the A antigen, can't receive B. O has both, so it can receive both. IV therapy, one of the things that we get wrong, and it's one of the most common things that we do. It can be to replace fluid loss. Contrary to Larry Mahaney, hope you're watching, it is to provide a route for IV medication. What? He's smarter than I am. So, this is not us just doing just because treatments. You need to keep line patency. And one thing that can keep line patency, contrary to Larry Mahaney, is fluids. Now, that doesn't mean you need to bolus fluids, but each time there's a venipuncture, while saline locks have their place, and they're good for hours to up to days, new IV venipunctures should require fluid administration for the first hour of some sort to get that venipuncture and that site used to the pressure and the change in the venipuncture. So even if it's a TKO, when we do a venipuncture, it is better to administer, even at a TKO drip, constant fluids through there, as opposed to just doing a saline lock. If you don't believe me, that's fine. Larry can come teach us. You have two types of pre-hospital fluids, colloids and crystalloids, while you're rolling your eyes over there. Don't get in a fight with me on Facebook and then tell me I'm dumber than you. He's got a lot less letters after his name. Tell me how to do my job. Colloids contain large proteins, have a high molecular weight. You know what I'm talking about. They don't diffuse across cellular membranes as rapidly as crystalloids. Why? They're bigger. They contain large proteins, which need acetone. They are not commonly found in the pre-hospital environment. However, there are some that we will deal with, especially on transfers. A lot of those being antibiotics, insulin drips, things like that. Oh, there you go. Petastarch, that's a good one. Plasminate, which we carry here. Yeah. Salt pore albumin. I've never transported that. Not saying it doesn't happen, but I feel like that's given once they're in ICU. Crystalloids, which are what we deal with, are your ringers, your salines, your hypotonic, dextrose medications. Those are all crystalloids. They are inexpensive compared to colloids. Most of them are. For reference, my plasma light is $19 a bag. Saline is $3. So that is a huge difference. Not that that matters to you, but there is a difference. You have your isotonic, hypotonic, and hypertonic. So we know that ringers and saline are isotonic. Our D5 and D10 are going to be hypotonic. What is an example of hypertonic we might see pre-hospital? Bueller? Huh?
No.
Is it the D10?
3% saline.
Oh,
Yeah, that's why. Because 3% saline is going to do what to the tissue? To the cells. It's going to draw water out into the vasculature, right? So that is a hypertonic solution.
Used it this morning.
What are we going over? Natural crystalloid plasma, protein, Very short shelf life. All blood and plasma products have a 21-day shelf life. I will tell you it's a nightmare to carry because we're getting it here and it's been nothing but atrocious. But it is good in the pre-hospital setting, can be very important. Increases intravascular volume by virtue of osmotic pressure. Can be used in hypovolemic shock, especially burns. Hypoproteinemia, which are low proteins, which there's no way that we will be administering that in the field.
You can get blood.
Huh?
You can get blood for one, right?
Yes. Why?
I was given bad information.
Don't get me wrong, an 18 is recommended. You can get blood through 22.
I was told that you had 18 for.
Some access is better than no access.
I agree. I was asking.
Yep. So, yes, you can. Again, 18 is preferred. However, you can't make an 18 fit in 20 size vein. So, I would say that we probably transport quite a few patients even out of the ERs that are got blood hanging with 20s. And it depends on the flow rate. In trauma situations, for sure. For anemic levels, you can give that through 20 or 22 because we're not full bolus for volume replacement.
It's just a lot different down there because we don't ever see, we are going to transport blood because they go to U of L.
Yeah, it can be done. No major contraindications when used in treatment life-saving emergencies. Again, you're replacing something that's already naturally occurring in your body. Now, too much of anything is bad. Too much water can kill you, right? But there's not a reactivity standpoint like if we gave the wrong RH factor of blood or something. Plasma proteins are neutral. I'm not going to go through all of these because we will go through all of these. I assume this is getting into colloids and those we will go over. I will tell you these that you do need to know for your drug card, so write these down. You do need to know head of starch. We're not going to go over them. Write these down, and we will refer back to them once we get to pharmacology as a whole. So head of starch is one. No. LRs is one. It may be referred to as Hartman's solution on National Registry. And I will go over with you later on how I recommend to do drug cards. We'll do that in pharmacology. D5W and D10W. Normaceline. One half normal saline, or 0.45. Nope. Okay. So those are the fluids. And then you also need to know plasma light. %. Missing anything? Who it was? Things that you need to consider when doing IVs. Number one, what size of catheter should be considered? 18 and 16 are not always appropriate, depending on the population. Obviously, if you give a 1-year-old an 18, you should hit the head with a shovel. It's going to be what you expect to give and what can be given. My go-to is a 20, 95% of the time. Some stuff will warrant an 18. I've never, in my history of Evernham, come across anything that is warranted at 16, and I've had some pretty nasty shit. Again, I know I've showed you guys the flow rate on 20s and 18s and 16s. There's no way that I need to replace 3 liters of fluid in an hour. There's no way that I need to replace 8 liters of fluid in an hour. Like I'm making them Kool-Aid at that. What type of IV catheter should be inserted? What type of fluid should be used? What type of drop set? 10 drop versus 15 drop versus 60 drop? Where should you do the IV? Again, ACs are everybody's go-to, but we have to remember, what is something that people constantly do, even all of you sitting here? We all move our arms, right? So the landing of your AC is important. Try not to land it where the center of the catheter is in the crease of the arm. Either have it ending there or starting there if you can. Now, that's not always great, and you can tell the people to sit there, keep your arm straight, try not to bend it a whole lot. And for the first 3 to 5 minutes, they'll do that, and you look over there, and they're doing this number, and they got a crease in it, and that's going to cause that vasculature to potentially rip, tear, or become infiltrated, right? Obviously, we need to go over our BSI. You should not need an order for an IV. We're not nurses. Make sure you have your appropriate fluid, the appropriate drop set. That is one of the biggest mistakes that I see. Is people just reach in a cabinet, grab a drop set because it's something is where it's not where it's supposed to be, and they'll get it out, and then they'll start running their fluids, and they'll see that it's just a steady stream because we grabbed the 60 drop instead of a 10 drop. Now, can you use it for a bolus? Yes, it's just going to take longer, and you can't calculate anything because it's a steady stream. Everybody knows what 60 drop and what 10 drop mean, correct?
Like 10 drops per minute or
10 drops on a 10 drop set is every 10 drops equals 1 ml of fluid. On a 60 drop set, 60 drops equal 1 ml. So when we use 60 drops, we're using that in a medication, like where we're doing Levophed, dopamine, heparin, epi, something that we need to know what the flow rate is to a more precise measure. Because luckily for us, with 60 drops, what is there also 60 of in a minute? Seconds. Crazy how that works, right? So we now can calculate, all right, if I need this dose, I need this every so many seconds, because that will equate to this dose. That's how we base our doses. Yeah, and when we get into dopamine clock and Levophed clock and all of those things, I'll break that down.
So is there a point to a 15 drop set?
No, it breaks it down into quarters instead of tenths or sixths or tenths. I mean, you can use them. They're cheaper because nobody uses them. So usually when people drive 15 drop sets, it's because they're cheap.
Like, well, the ones we use it, we've got to try. It's like all in one. They're like adjustable. And
They're a
it's either-
burette.
Yeah, I guess it's like a barrette set, and we can adjust, you can like twist it. It's either a 10, 15, or a 60 drop.
Yeah, that's probably for covering for the potential for a mistake. So no matter what you grab, you can use it. Problem with those that I've seen is there's failures on those, and if you don't line the stuff up correctly, then you're off. Those mechanisms can fail. It's to each their own. I don't want to sit here and say that there's one's better than the other. Burettes have their place because then you just fill this chamber with this amount of fluid and no more than what you put in that chamber is going to be administered. So that's a safety if you're really bad at, setting drip rate. You go and you're like, oh, fuck, it prevents that. It all depends. But make sure you have your administration set, your catheter, you have your extension tubing or hub. You have tourniquets. You have either iodine or alcohol. Alcohol is preferred because iodine interacts with some blood draws and things like that, medications. You've got some type of gauze, some type of security device. We use commercial security devices here in the foam. they have those flimsy ass fucking other clear tegaderms that as soon as you take it off, it clings together, and then you're sitting over there with it stuck to your gloves and look like you got a Chinese finger trap on your fingers. Antibiotic ointment, never seen that in a start kit. And a short arm board. I do use those on the younger or older population that just have a tendency to not follow directions. You can use those like wrist splints, those SAM splints, or you can use a SAM splint if you want to use the whole thing. I know some people cut them up and, you know, give it from here to here, we'll secure it down here, secure it up here, and I'll just keep that patient from bending their arm. Open the bag of fluids. I don't usually do that until I know I have a patient site. But do what you want. If you do use it, make sure you check that it's not discovered, there's no particulate matter floating around, that it is in date, it is the right fluid, and you're going to give it to, obviously, the right patient. Open and inspect the IV tubing. Make sure the extension tubing's there. Close the clamp on the tubing before you puncture. That's just so you don't have shit going everywhere. Remove the sterile cover from the IV fluid in the administration set. And this, please don't take this a bad way. Is there somebody in here that has not set up a drops or like a bag of fluids? Everybody's done that. We know what we're talking about. Here's the saline bag, everybody at some point. So we know to squeeze the drip chamber, get all the air out of the tubing. Please don't give them 30 ml of air. Be a bad day. Hang the bag on the pole, or you know, the security devices on the top of the ambulance have a tendency to hit you in the face no matter where you go. Place the tourniquet on the patient. Find the vein, palpate it, prepare the site by cleansing it. Contrary to popular belief, if you go back and finger fuck it, it's like to make sure it's still there, you're supposed to cleanse it again, just to prevent from phlebitis. Make the puncture using the appropriate sterile technique. I will tell you, it is smart in your narrative when you're doing it to say IV started in left AC using aseptic technique. That covers, as long as you did it. Like, don't just type it and be like, you know, I rubbed mud on it and started the IV. As long as you're doing it properly, using the term aseptic technique, it's good to put in your narrative, and it protects you from anything. Connect the IV tubing and remove the tourniquet. Now, hospitals do this a lot where they don't have the extension sets, they just direct connect. I don't know anybody that direct connects in the field because we don't always give fluids, or we get different fluids. So I would say at a minimum, you have an 8-inch extension set, or you have the male adapter. Make sure whether it's a male adapter or an extension set, you still prime those as well.
CRH, that's, we use this little hub.
That's what we use here,
Yeah.
but our IVs have the extension set. But again, some of them will just use a plastic catheter straight to the hub. Make sure that you flush it first. I know a lot of us, again, don't go directly to fluids. So with your flush, don't sit there and slam the shit. Push it at a normal rate and make sure that there's no infiltration. Make sure you draw back. If it's valved or something, you may have to reposition. Go through all of that. Never applied antibiotic ointment over a puncture in my life. Secure it with tape. If you're still old school and use tape, that's cool. It still works. I know you can use the V method. Wrap it around and you come across one way, you wrap it around and go across the other way. That way there's direct tension applying both directions, so it's less to move. Again, we use the foam commercial devices here where it's got a little see-through window to look for infiltration, and then it secures all the way around. We typically still wrap that in co-band just because people can be sweaty, people move, people are hairy, whatever they can be, but it helps. Apply a short arm board if you need to. If you mix anything with the bag, make sure you label what's in there. They tell you to put the patient's name on the bag. I don't feel like I'm ever disconnecting it, knowing here's your patient, here's your bag after I've started it. I've never wrote the patient's name on there, but it might be a good idea if you have multiple patients, that might be a good idea that you're transporting, just so you can know that who's who. But again, if you're going to cover the site completely, it is a good idea to take a Sharpie and write the size on there, whether it's an 18 or a 20 or a 22, just so, you know, you get handoff and you know the report you give to at a hospital isn't necessarily the nurse that's going to treat the patient. So if you completely cover the site and they can't see the color or whatever, it is good to write on there what size catheter is underneath so they know. Because again, if you've got bilats and one's an 18 and one's a 20, and they're both covered, they might want to say this needs to go in quicker or faster, or it's going to flow better here, just so they have an idea of what it is. Call your medical control, let them know you started this, because that's the live beat. They're going to be thrilled to hear. Now, this is something to consider as well. We may not, your dehydrated patients, your fluffy patients might be harder to feel where certain veins may be. Everybody's anatomy is similar in some sort, so knowing where these sites are coming down are a good idea to, if you ever have to blind stick someone. It is not recommended to ever blind stick somebody, but you may have to. So knowing that your main cephalic one comes through the center and all of those things to where, hey, I don't feel anything, but I know something's supposed to be in this area, it's a good starting point for you to either try or feel. You've got the ones in your legs. You've got your popliteal, you've got your medial that you can use. You all know how to apply a tourniquet, right? When we puncture the skin, I noticed some of you last time were taking our time. Don't take your time, that makes it more fucking painful. You look like an airplane crashing on its nose where it just skips across the skin. And now they have a nice tattoo from the 9 bumps that you made before you inserted. Please be quick. And I'm going to start some on a couple of you today to show what I mean by be quick. Secure the catheter. Again, those are the non-foam kind. We use the foam here. Same idea. You can see the catheter in the site, look for infiltration or leakage around the site. Secure below, and then wrap it around and secure the top. Don't let this 8-inch pigtail just hang because it's going to get caught on something. If you do a collection of blood samples for the laboratory, always put those in a bio bag. Make sure those are labeled with the patient's name, the patient's date of birth, and the time the blood draw was done, because after a certain time, those labs are no longer good, because they'll start to coagulate. Any questions? 12:30, be back, 45 minutes early.